I'll do it that way. First of all, thank you very much, Omar, and ESBD for organising today's events, which so far at the beginning have gone very smoothly. I'd also like to say how delighted I am to see all of my DDS-MAP colleagues and compatriots here. It's a great pleasure to be physically all together in, as you say, a very sodden Brussels for the morning, and a complete contrast to yesterday where we were all dying of the heat. It's marvellous to be here, I have to say. I was just looking at my photograph and thinking, my goodness me, who is that damned handsome devil staring back at me? So that photograph was taken a little while ago, and I really will have to change it. As I said, I'm very, very glad to be here. I think we're going to have a marvellous day. We've got some marvellous speakers, and I hope we have a very good debate. One of the things that has really hit me today, reading my news feed, which I have to say did depress me a little as I was reading it this morning, is when we first were writing the application for DDS-MAP, Russia had just invaded Ukraine. And as the years of DDS-MAP have gone on, actually, it's really hit me how increasingly relevant the project idea and what we're doing in DDS-MAP has become, sadly, for all the wrong reasons. So we're really, I think, in the context of where we're going, both in Europe and globally, DDS-MAP and the things it's trying to do are going to become far more prominent in terms of the dialogue that happens within the health services, particularly in Europe. But we've got lots of positive things to say in the context of that wider environment. That's all my opening remarks. As I said, wonderful to see everyone in the room, wonderful to have so many people online, and to our DDS-MAP colleagues who couldn't be with us today, some because their flights were cancelled. Very, very warm welcome. So thank you, and I'm going to hand you over to my ESPD colleague.
So hello, good morning as well from my side. My name is Ivana and I'm the head of project at ESPD. I wanted to start by saying apologies for the weather that we couldn't make it second day of sunny, but maybe it was also good, you know, after the heat to get some rain, obviously. It's really a truly pleasure to see you all here, and welcome to Brussels. Also welcome to all the participants that are, you know, I think we have more than 10 countries present in the online, so that is also wonderful to see. I think as you already mentioned, as Professor John, you mentioned, today marks a really significant milestone of our DDS-MAP project, particularly in terms of our collective efforts to enhance digital skills in healthcare system, but also aligned professions. And that's for us is a very important element. Over the last 2 years, this project really had a powerful vision, which is that every healthcare professional, including nurses, administrative staff, managers, and also allied professionals like social care workers, should feel confident and equipped when working with digital skills. And also 2 years ago, when we got this invitation to join this project, I mean, I don't think we doubted for a second, because that is also the lack of digital skills and the lack of digital literacy is something that we share among these two ecosystems, both the healthcare and the social care. And it's where we can really work together. It's COVID-19, even though we are after the pandemic many years, still make us realize that there is a really essential need for services to be digitally transformed and to use more digital interventions also among all care professionals in order for them to have the sufficient knowledge, the sufficient training, and to be able to enhance effectively with digital technologies. However, not all of these opportunities that are related to skills development, especially on digital skills, are always available to social care professionals, as a lot of these funds would often go more to healthcare professionals, leaving a bit the disability support providers out of the picture. Nevertheless, Thanks to the EU for Health program and the DDS-MAP and all of our partners, we are very happy that this project really brings that fresh perspective and opportunity for us to engage with a lot of universities and tap into all the resources that they offer. And it really has been a pleasure to work on this project all these 2 years. We have developed a lot of outputs. Some of them you can see them as well today, and a lot of the sessions will talk about it. We ourselves will also do testing of one of the modules of the curricula that was developed, and we are very happy to do. And really big thanks to both UCD and ECTU for facilitating all of this learning path. I will try to wrap it up and say as well that both for us, I mean, we as ESPD truly believe in the power of digital learning and online learning, and that's not only present in this project. We also have our own platform. There is the ESPD Knowledge Hub, and my colleagues here sitting in the first row are responsible for that. Hi to Cal. We are promoting a lot of skill development opportunities and courses, both in terms of digital, but also other person-centered skills that can be useful to all care professionals. And we warmly invite you to explore that on our website. Also, lastly, to say that our efforts in terms of the digital transformation of the care sector doesn't stop here. As ESPD, we are also part of the Pact for Skills, particularly in the area of long-term care. So 2 years ago as well, so very coincidental, we started the large-scale partnership on long-term care. And we also are now leading one of the blueprint initiatives under, again, the Pact for Skills that is specifically related to enhancing digital and person-centered skills to care professionals, also tapping a bit to some nursing professionals. So there is some links that are developed. We are currently doing one of the courses that is related to rapid response in terms of digital skills for care professionals, and we will develop a new training curriculum. And I'm only mentioning this to all of you here to also let you know that this journey doesn't end with DDS-MAP, and that we will also be happy to share all of this and build upon everything that we have learned through DDS-MAP and how important is this investment in lifelong digital learning. And I'll close with that, thanking especially to all of our partners for all of these journeys these 2 years ago. Thank you very much, especially to SETU and all the consortium members, the participating organization, and the very mission, the healthcare professionals and all the care professionals that are committed to lifelong learning. I hope today it's a vibrant and inspirational exchange for all of you, and welcome again and enjoy all the sessions. Thank you very much.
Thank you, Ivana, and thank you, John. So now we are heading to our first speaker to deliver the policy keynote. So we welcome on the podium Dr. Petronila Bogart from the European Commission to deliver the first policy keynote for the session. And can we have a big round of applause for her? Thank you.
So good morning, everyone. It's a real pleasure to be here. My name is Petronila Bogart. I work in the European Commission in DG Santé, and more specifically, I work in the unit C3, which works on the state of health. So we do lots of different things. We work on the European semester, so we monitor health systems across Europe. But one of the key files in our unit is also workforce. So this is very important for us. That's what I'll be talking about today. And also I work on Thank you. And also I work on digital health. So the link of digital health with workforce is also something we'll look at in the unit. So as you might know, we have a commissioner at the European Commission that is assigned to health. And the commissioner, he's called Várhelyi, has pointed out several key initiatives in his mission letter. So the different areas he covers are Critical Medicines Act and Pharmaceutical Reform, the European Biotech Act, availability and competitiveness of medical devices, step-up work on preventive health, antimicrobial resistance, EU injury on impact of social media, modernize rules of animal welfare, prevent and reduce food waste and food safety standards, then an action plan on cybersecurity of hospitals and healthcare providers, and the completion of the European Health Data Space. So here, lots of keywords, but you can already see there's a lot of interaction with workforce here. There's a lot of areas where health professionals link in on these different activities. So health workforce is really at the core of our work. More specifically, what is written in the mission letter and has been assigned to Commissioner Varley is to complete the European Health Union. You may have heard about the European Health Union, and I'll tell you a little bit more about it in the next slide. But one of his priorities is to complete this European Health Union by further simplifying supply chains, improving access to most advanced treatments, to boost competitiveness, resilience, and security of health systems, and working on strategic inventories. So when we think about boosting the competitiveness, the resilience, and the security of health systems, this is something that cannot be achieved without a strong, skilled workforce. And then another point is to continue to build on a One Health approach. So a final word on what this European Health Union is. It has 4 pillars on which it is focusing. The first one is on health security, so this is regarding preparedness. What we have there is, for example, to strengthen the health security frameworks. Also there's a lot of training that comes involved with that. There's a joint action on preparedness, surveillance, risk assessment, early warning, and response. There are joint actions on these. But also there's a specific article in the new cross-border threats, the serious cross-border threats to health regulation, there we go, which specifically also looks at training of the healthcare workforce. Then there's a pharmaceutical strategy for Europe, which looks at more access to affordable medicines for patients. The European Beating Cancer Plan, which supports actions to coordinate and supplement member states' efforts at every stage of cancer. And then we have the European Health Data Space. And I think the European Health Data Space is also something which is very important, which links in to a lot of elements of digital skills. Because what the European Health Data Space aims to do is to really harness the huge amount of data that we have available on health across Europe, but really make use of it. Because as some of you might know, we are data rich, but rather information poor. The health sector is one of the sectors which collects has most of the data comparing to other sectors. And this can be hugely beneficial to patients and also can be very much used by healthcare professionals to better find better medicines, but also for potential uses in when we think about upcoming digital technologies. And then finally, there's mental health. So here it's about prevention of mental health, better screening, treatments, etc. So that brings me to the health workforce. And as I said, the health workforce is really at the core of making sure that our health systems are resilient. As we all know, during COVID-19, our health systems were put very much under pressure, and those who suffered maybe most are the health workforce. But there are some challenges that we see, and the health landscape is evolving as we go through time. So the European Commission and the OECD launched one of our flagship programs is a report that we publish on a regular basis. And this Health at a Glance, it's called Health at a Glance Europe 2024. I invite you all to have a look at this report. We asked to prioritize 2 topics. The first one, healthy longevity, and the other one, looking at health workforce shortages. And what came out of that report is very clear, is that we had an estimated shortage of approximately 1.2 million doctors, nurses, and midwives in 2022 across EU countries. So of course, this is a real struggle, because not only do we have a shortage of doctors, but on top of that, our population is aging, as we all know. Our aging population is not only aging in good health, but unfortunately also with disabilities and multiple diseases that need to be treated at once, so different comorbidities. So it's important that we are able to cope with this demand of increasing healthcare that is needed across the EU. Yeah, so indeed on the right side of the slide, you can see the EU health workforce is struggling to keep up with this aging populations. So what other challenges do we have? So not only the population is aging, but also our workforce is aging. As you can see in the slide on the left side, this is an evolution between 2005 and 2022, and we see that over a third of doctors are at least 55 years old and therefore can be expected to retire in the coming decade. And so this adds additional pressure to be able to cope to the demand there is, because we also struggle with the supply. And this isn't only the case for doctors, this is also the case for nurses. Of course, there are big differences between countries. Not all countries have this to the same extent, but it's definitely something that we really need to consider. Another thing we need to consider, and that's one of the challenges, is the difficult working conditions. And here, the working conditions have really proven to have a high job strain. Work intensity and burnout is very high in the health sector, and is actually highest among all sectors in recent surveys that have been carried out at European level. So to be more specific, in 2021, so considering it's in the context of the pandemic, almost half of workers in the health sectors, and the long-term care residential sector, also 47%, so almost half, reported high levels of job strain on average in EU countries, which is a much higher proportion than workers across all sectors, where the average is around 30. And looking at specific occupation, job strain was about 2 times higher among nurses, at a bit higher than 60%, and personal care workers at 55%, than across all occupations on average across the EU. So that really makes us think, it's not an easy job to work as a health professional. And this links in with the third challenge we have, is that there's in some countries decreasing interest in health careers. So we do see, especially for nurses, that there have been less students registering to study the nursing profession. Also in some countries, this is the case for physicians. So many countries are really trying to address this, and we do see that in some countries in the very recent years, they've been able to increase this registration of students, but we need to acknowledge that maybe the profession isn't as attractive as it used to be. Then we have a shifting composition of the workforce. So here we have more and more health professionals, and especially physicians, where they specialize. So we see a lack of GPs, of primary physicians. On average across the EU, 1 in 5 doctors were GPs in 2020, whereas 2/3 were specialists. And when we think about the high load of non-communicable diseases, so cardiovascular diseases, cancer, there is a lot of prevention work to do, and especially primary care can play a really important role in supporting our healthcare systems to deal with this demand of healthcare. So it's very important that we keep on investing in primary care and in prevention and promotion of health. And finally, the last challenge, which I wanted to mention today, was the uneven geographical distribution. This is not the case in all countries, but we do see many countries that for some areas it's very difficult to get access to care. And I think here digital skills can really play a role. Thinking about telemedicine, I think during the COVID-19 pandemic, many countries had a push in that direction. So yeah, here the work that is being done to reinforce skills play a hugely important aspect. So yes, this geographical distribution of health workers where they're lacking is called medical deserts. But of course, with challenges come opportunities, and we need to find the best way to recruit and find recruitment and retention strategies across the EU, where upskilling and reskilling play a key role. So one of the first things is we can focus on improving health workforce planning and forecasting, so really anticipating how the needs are going to evolve over time, and looking at different scenarios and supporting countries in preparing for this. Of course, there's increasing in education and training, so not only for students in training, but also continuous professional development across lifelong learning, as of course DDS-MAP is doing. Improving working conditions and well-being is another pillar which is very important. And lastly, innovating and optimize the use of skills and new technologies, because these offer huge opportunities where we can try to increase our efficiency, but also maybe allocate more time to the patient rather than, for example, administrative activities. So that brings me to what are we doing to address all of that, because these are lots of challenges. And so I focused here, I split the slide a bit in two different areas. So the first one is more general on shortages, but of course shortages cover both areas, obviously, but that focus on working conditions and skills. So we have had a cluster of 5 projects, and these focused on medical deserts, so these areas where there's less access to medical care because of the facilities or the health workforce being available there. So we had 3 projects: AHEAD, OASIS, and ROOT, which specifically looked at tools or metrics of medical deserts, country-level research, and really build policy briefs and consensus building to find solutions, guidelines, and how to address this problem. So I encourage you also to have a look at these different projects, which have come to an end, but which have really found very interesting results, which can be put straight into practice. Then we had some on tasks shifting, so we know that some activities can be shared, for example, between physicians and nurses. So here we had a project which is called TASHI, which specifically looked at tools, practices, case studies, training materials, and so forth on task shifting. And then retention, we had Meteor, which did a survey on mental well-being in 8 hospitals in 4 member states and provided policy recommendations to improve retention of health workforce. And then one of our very important joint actions currently running is HEROES. So this specific joint action you may have heard about is currently working on workforce planning and forecasting. So it wants to improve the database used for health workforce planning, develop effective tools and methods, and define the best skill mix needed for professionals to carry out health workforce planning. And so currently they're working on 20 national and 2 EU action plans on strategies to enhance planning of the health workforce. And then in the middle, you have 2 actions that we're doing in collaboration with the World Health Organization. So we have currently a nursing action, which has been running for less than a year. And this nursing action looks at improving specifically for nurses retention and recruitment practices. So it's really trying to attract more students and people in mid-careers to nursing profession, and then measures to retain nurses. And they're also doing massive online courses, open online courses to address these, but these are still in development. Several member states are joining this initiative, and if any more member states are interested, they're more than welcome to join as well. And then also we have a survey on guidelines on mental health of the health workers with WHO. So looking, indeed, at a framework and guideline and looking at the well-being of our health workforce. So then I want to focus a little bit on the health workforce skills, which is the topic of today. So what's really important is that, technology is changing over time, and this needs for the skills to be upskilled, but also reskilled potentially, because this leads to new emerging occupations. So there are new types of roles that will be needed, that are already needed, but that will be needed even more in the future. So the way that we see technology is that it should be used rather for augmentation rather than full automatization, not replacing any health workers, but really being used as a tool to support health professionals to be able to carry out their profession. To be able to carry out their profession. So, for example, as you all know, the technology now can offer opportunities to reduce administrative load or to support with improvement of accuracy and efficiency. So we want to make use of these evolving technology. To be able to do that, you need to make sure that the skills evolve, adapting these changes in technology. And so what is needed and what was already discussed by the colleague just earlier is that you really need training in digital and data literacy, data analysis and system management, but also it may require changes in soft skills such as communication, which are also some of the courses that are offered by the colleague of Be Well, but also DDS-MAP, because thinking about telemedicine, for example, the way you will interact with your patient will be slightly different. And also what's very important is to understand privacy and security practices such as cybersecurity. I think the DDS-MAP course really nicely showcases this. And it's important for health professionals to make sure that they're informed about responsible and ethical use of sensitive patient data. And I think if we together do this in a sound and profound way, that this will also enhance patient trust and ensure even higher quality care. And then finally, what will be important as well is to collaborate across different disciplines because using this technology might need understanding of other sectors or might need understanding of other disciplines. So yeah, it will be an important step as well to do that. So that brings me actually to the Pact for Skills. So it was already mentioned, I think, earlier. So here we have Be Well. So the COVID-19 pandemic highlighted really the critical importance of skilled and resilient health workforce to adopt digital solutions and emphasize the needs for sustainable, environmental friendly practices in the healthcare sector. And so in response to these challenges, the European Commission launched two key initiatives in recent years. So the first initiative is a skills partnership of the health ecosystem. And in that health ecosystem, we have three large-scale partnerships. One that was just mentioned earlier on the long-term care sector, but there was also one which is specifically focused on health workers, which Be Well is pooling, and also one focused on the health industry. And so, what are the objectives of this? It's really to map current and future skills needs in the health sector, aligning education, training, and employment needs at regional and EU level, and facilitating cross-border mobility and recognition of qualifications and promoting continuous professional development. And so this leads me to the second initiative, which is the Be Well Blueprint. It was launched in December 2020, and it really focuses on upskilling and reskilling the health workforce on digital and green skills. And so they do multiple things. One is the partnership I just mentioned, but they also have a strategy. So this really looks at how we can develop and green and digital skills across the EU. And they have an open consultation, so I very much advise you to share your opinion on these. And they also develop pilot trainings that have a platform with all different types of trainings, which the DDS-MAP trainings will also be on. So it kind of pulls those different initiatives together. Then we have under the EU for Health program, so this is the specifically funded under the health strand, we have 7 training programs. And so this 7 training projects, one of them is DDS-MAP. What did they do? They develop and implement training modules, and they focus both on medical professionals and other health workforce on continuous professional development, but also non-clinical staff, which I think is also important. So working in health systems, this can also be health authorities, think about ministries of health or public health institutes, for example. And so the focus of the training are skills needed for this transformation of the health systems in new care models, digital skills as part of patient care, and non-clinical staff. So digital skills for procurement, planning, management, and so forth. So here we have 60 million that's been invested, and we will be reaching over or just under 18,000 health professionals across the EU. So I think this is very exciting, and it really shows this push to have these skills upskilled and reskilled. And so each of these 7 training programs have at least 1 module for general medicine, 4 modules for nurses, 3 on specialist professionals, and for the non-clinical staff, there are 2 models, and there's also at least a train-the-trainer module. So, and all of the modules, of course, need to include a module on digital skills. So this is just an overview of these 7. I'm not going to read all of them out, but of course, DDS-MAP, we're very happy to see it as one of the 7. They all work on digital skills, but in a slightly different area. So for example, we have one on antimicrobial resistance. There's the second one focused specifically on digital skills in hospital setting, skills on gynecological endoscopic treatments, digital skills in oncology, general digital skills and transversal skills. Then you have DDS-MAP, and then transition, which is on cancer and prevention, decision-making, monitoring, and supportive care. So now I provided you an overview of different activities we're doing that are covering multiple member states at once. But we also have initiatives and actually quite big amount of funding, which are country specific. And these are sometimes types of funding which people are less aware of because they work directly through the countries, they work directly through the ministries of health. But these are huge funds, so I think it's very important that you are aware that these exist as well. So we have the European semester. What is the European semester? It's an assessment we do of the health systems every year. So this is part of a bigger economic investment assessment that happens of the countries in general. And so then we provide in these assessments every year recommendations. Then we have the Recovery and Resilience Facility. This was a fund that was released during the COVID pandemic, where each country made up a plan of how they wanted to reboost and recover from the pandemic. And then we have technical support instruments which work very specific. So it goes into one country where the Commission provides support from the moment the topic has been decided to its actual implementation and its full, the full carrying out of the project. So here, what I just wanted to highlight is that for the European semester, we've already from 2020 provided a country-specific recommendation. So in these, in the European semester, there are recommendations that are provided. So we just released the recommendations for 2025. And what we see here is that we had 7 countries which we specifically asked to strengthen their health workforce. So it's about tackling shortages and the geographical distribution of the workforce, adding human resource, improving working conditions, retaining and attracting skilled work. So as you can see, the Commission is really pushing also member states to address these issues. Then we have the Recovery and Resilience Fund. So here you can see 3 countries that are dedicating specific investments, but there are many more. And the technical support instrument has one specific flagship, which is on digital skills. So in Italy, Spain, and Romania, there's actually a specific contractor supported together with the Commission and this specific member state to roll out a full project from A to Z on that specific topic. All right, and that comes brings me to almost the end of my intervention. Of course, we're doing much more. I work in Santé, so I'm not an expert on all these other initiatives that are happening, but there are many. So I'm just going to mention a few. For example, there's the European Care Strategy that looks at improving the situation for both care receivers and people caring for them. There's an action plan on labor and skill shortages. There is also emphasis on migration policy with the EU talent pool. There are regional policies as well. For example, the Harnessing Talent Platform has 4 working groups. One is specifically on health and one looks specifically at healthcare workforce as well. So supporting regions. We've also had projects actually within our unit on forecasting together, working together with the Joint Research Center. And then maybe just two more words on the latest release and the latest launch of the Union of Skills. So what is this Union of Skills? It's a new strategy introduced by the European Commission on the 5th of March in 2025, and it really aims at enhancing Europe's health capital and global competitiveness. And so in a Union of Skill, everyone in Europe should be empowered to develop skills. In a Union of Skills, there's competitive companies that can find people with the right skills, and skills and qualification are transparent, trusted, and recognized. So what is it going to work on? And I'm just going to emphasize one area, but it's building skills and for quality lives and jobs. This first area is mostly focusing on basic skills, but the second area is about upskilling and reskilling for the digital and green transition, which is very relevant for you. And so here what the Commission will do, it will propose to expand the use of micro-credentials, and we have actually a panel talking about this later on flexible learning solution. It will also reinforce the Pact for Skills, which BWell is part of, and the other colleague was mentioning as well, to help more workers gain new skills in strategic sectors, such as the health sector, and to pilot skills guarantees to offer workers risk of unemployment the opportunity to gain new skills. Then it's also about helping the free movement of skills. So there is already a regulation on the recognition of qualifications across the EU, which is very important for health workers. But so there will continue doing work on this. For example, also to promote mobility for teachers and students across the EU and across Europe. And then finally, it's about attracting, developing, and retaining talent for Europe's future. And here it will set up an EU talent pool for the recruitment of job seekers outside the EU and at skills levels, and it will promote and attract workers from within and outside Europe. So I think you're not too bored of me now, because this was a lot. But it was really a pleasure being here. I'll stay a bit around and listen to more of the sessions today, but I really want to thank personally also DDS-MAP because I've looked at the training courses and I've followed them myself, and I think you have managed to find a way at making them attractive and engaging, which is very difficult. I mean, we all spend so much time on our computers, and then having to, especially for health professionals who have so little time, to then go again to your computer and follow more courses. But I think you've managed to find a right balance between saying things you already know, but also bringing new things which you didn't know. So I actually learned as well by following the training courses. So I encourage all of you to use it and to disseminate it across the networks that you have in Europe. And thank you so much for having me.
Well, first of all, because I'm going to lead the panel discussion, so first of all, Petrina, thank you so much for coming. Very much appreciated. And can I say thank you so much for your praise of DDS-MAP, which we have recorded and we're going to use in our publicity. And obviously, in the context of the development of the module offering, the online offering, it's reflective of the level of skills within the team that we assembled amongst ourselves. And I really think we need a little bit round of applause actually in terms of the team who actually developed the content. And I think it's a key element that we forget in the context of education. Education is more than about just imparting information. Education is about getting people to be interested so they want to learn more. And we forget that it's really important, particularly in an age that's so focused on the visual, that things need to be visually attractive as well as just interesting information that you're picking up. So again, I think that idea of engagement is really very, very key. How we can engage people who are often tired and overworked in the context of what they have to do today. So that's a really key thing that we really need to develop going forward into the future, I think.
I really liked how you added in like this YouTube videos and like short recordings of other sessions, because also like sometimes when you read something you're like, oh, this is interesting, and then when you've sparked that interest you might want to know more, and then you can click on it and then you can listen it to during your commute or other ways. So it's really nice how you've managed to indeed exactly do this visualizing together with the training. Thank you.
Yeah. So on that note, on a very rainy day, so outside is less engaging than it is in here. I'm going to open up the panel discussion, but first of all, can I just say, can we give Petronella a round? So we're going to have a panel discussion. I'd like to invite up the members of the panel. So that's going to be Professor Dominika Werbniak. I've known Dominika for many years, but I still can't pronounce her surname, so my apologies, Dominika. And also, can I ask Andreas De Luga to come and join us? And last of all, Federica Magari, who's the Executive Director of the European Health Management Association. So Federica, you're very welcome. And you're involved with Be Well, aren't you? So, which is a really exciting initiative that's arisen out of Pact for Skills. I was delighted to see when Be Well was launched that we were really addressing Pact for Skills in the context of the health services. So I'm just going to give a little bit of an introduction to the panel discussion. Each member of the panel will then have a short PowerPoint presentation that they're going to present, and then we will have, hopefully, a lively open discussion, and that will get us to think about the challenges that we need to address within the European health ecosystem going forward into the future. So without further ado, there's a clicker, and the thing kept changing earlier on, and then it just suddenly occurred to me, it was my damned hand pressing on the thing that was moving it under. So anyway, I've learned a new skill today, how to use one of these things without not realizing quite what it was. So I'm going to hopefully move this slide forward. So when we were writing DDS-MAP back in mid to late 2022 in relation to the call, Russia had just launched its attack on Ukraine. And up until that point, really, how I'd certainly conceived of things that had happened to health services, like what had happened to the Irish Health Service during COVID, when we had a massive cyber attack, which caused more stress to the health workforce than managing COVID did, was that this was all criminal related, and it was about getting money and holding people to ransom. It never really occurred to me that this had some other motive behind it other than criminality. I think what events have subsequently shown, both in Ukraine and elsewhere, is that it's really highlighted that health services are a strategic asset for countries and for the European Union. And because they're a strategic asset, they become a strategic target for malign groups that want to undermine, and Petronella mentioned this in terms of public trust, want to undermine public trust in a very key element of society. If you think about it, for most of us, the first people that hold us when we are born are not our parents. The first people that hold us when we are born are healthcare workers. And often, these days, the last people to say goodbye to us are healthcare workers, because many of us will die in hospital settings. It's therefore one of the few shared experiences that most of the population have. in an increasingly individualized world, the one thing that we all share is we all at some point see a doctor or a nurse or another type of healthcare professional across our lives. So it's a very common shared experience. So in that context, it's really important if you can undermine confidence in that common shared experience. It's a way of breaking bonds in a society, but it's also a way, of course, of undermining faith in our government. So, and we're seeing this. What is one of the big complaints that is happening in many countries within the Union? Our health services aren't working. So the more you can disrupt them, the more you create that lack of faith in our broader system of governance, our broader belief in what our societies stand for. And that's come much more to the fore. And also in relation to that, of course, is that the importance of our defense of that system has come much to the fore. And what is the primary defense? It's people. It's the people who work within the health services. And what's the primary way these days, other than blowing up hospitals, what's the primary way that we are attacked? It's through our increasingly networked system. So making and encouraging people who work within the healthcare system to be aware of that threat and aware of their importance in defending the system against that threat has increasingly come to the fore. And within DDS-MAP, of course, one of our primary aims was to reinforce the digital skills and digital awareness of staff in relation to that role. But little did I think when we were assembling and we had in our first talks that it would become so foregrounded in the way it has been in a frighteningly short period of time of 2 years. So in that context, DDS-MAP and what it's trying to achieve has become even more relevant than it was when it was first funded under EU for Health. The other element to that, of course, is that the scale of the threat has actually greatly expanded. So what is happening now in terms of targeting, in terms of that undermining of confidence, is that we don't get mass attacks on the system. So we don't suddenly find, in the way that we did in Ireland with the Conti attack in COVID, during the COVID lockdown, that the entire system shuts down. That, if you like, has become too obvious. So what we find actually is that specific institutions, specific hospitals are now targeted. So you might find that your local regional hospital suddenly becomes unavailable. So the broader system is working, but suddenly my region doesn't work. And the strategy behind that is just to make daily life inconvenient. And again, that's something that we need to be aware of, because currently the way that these attacks are presented is that national way of thinking, but it's become more subtle than that. But here are just some statistics, recent statistics in relation to attacks relating to 2023. And you'll notice that 42% of hospitals at some point had a cyber incident, were cyber targeted. And the way that you get a cyber targeted incident is they have to get through the system through an individual. What's very interesting, of course, is the reports that then report how these things get in. They focus on the technical defenses. We need better firewalls, etc., that sort of thing. Actually, what we need is better training and more regular training. And again, one of the things that DDS-MAP is trying to address is that regularity of training. It's marvelous to go on a course about cybersecurity. And I did that course 5 years ago. Well, I don't know about you, but I'd prefer somebody who was going to give me CPR having done a training within the last 3 months than in the last 5 years. So I want a more regular training package being delivered rather than a one-off and then we tick that box, now all the staff are cyber trained. So I've emphasized here it's the human factor that's key. But what we've got to recognize is that a couple of things. Firstly, in terms of our use of technology, it is an incredibly dynamic, fast changing environment. And again, this goes to one of the things that Petronella raised, stress. We've got the day-to-day aspects of stress that have always been with us in terms of healthcare. The last time I was ever allowed to touch a patient was 30 years ago. But goodness me, one of the things that I see is the stresses that healthcare workers have today, I had 30 years ago. So there are some core stresses within the system that never change. And that's related to the fact of human-to-human interaction. I, as a nurse, dealing with a patient and their family, that's actually a very stressful activity. You're dealing with people who are often, when we're in hospital, we don't want to be there. We're having to come to terms with illness. Our families are having to come to terms with illness, and therefore they're stressed. And it's one of the very important roles of healthcare workers to help families, help the patient manage their stresses. But that help is in of itself very stressful and takes its toll on people. So we've got those very core stresses. But now added to that is a thing that I never had to deal with 30 years ago, technology. The highest level of technology that I had to deal with 30 years ago was a thing called the telephone. I didn't have computers, I didn't have networked systems, I didn't have charts I had to look at and then input. Pen, paper, and the telephone was all I had to worry about in relation to delivery of healthcare. Now, of course, a very different world. A world where we're constantly upgrading the technology. And therefore, as a healthcare worker, I'm constantly having to think I've got my technology sorted out, and then they suddenly change it. And now I'm having to deal with new technologies. So that very fast, dynamic, we're trying to deliver a better system through our technologies. But again, that takes its toll on the health workforce. And we need to think about that in terms of training. We need to make training as easy as possible in such a dynamic world. So we can't keep repeating the old ways of doing things. Of course, that very famous phrase, the definition of madness is doing the same thing over and over again and thinking you're going to get a different result. We have to think and evolve the way we train in relation to the way that we're asking people to engage with new technologies, taking into account also the traditional stresses that they also have to manage in their jobs and in their role. And that's important in relation to the policymakers, but it's also, of course, important in relation to the educators. And I and many of the DDS-MAP colleagues in the room, we are educators. And we can become a bit staid in our ways and traditional and, PowerPoint is where it's at sort of idea. So we have to adapt constantly. Everyone has to be aware now to adapt. And one of the things I would suggest in relation to future funding under EU for Health is that we need an element of application which says, and how do you propose to adapt this training going forward into the future? What's the strategy around developing it further, and how do you think it's going to be changed? What are you building in to your training strategy to accommodate change? The other element And again, it goes to what Petronella was saying in terms of persuading people not just to engage in training, but to stay within the healthcare workforce. We're not only, it's not only a failure to recruit in terms of getting people to sign up to become healthcare workers. Actually, it's persuading them to stay. One of the marvelous things about healthcare training for all disciplines is that it emphasizes things that are called transferable skills. We have things that actually can easily transfer into other contexts. I've just mentioned one, people skills. People skills can transfer into other contexts. We produce people who are very technically skilled. They're very dexterous. We produce people who are fast, who think fast on their feet to adapt to problem solving at the time. These are very, very valuable people skills that other industries would want. One of my friends worked in intensive care, and very technically skilled, and the company that was selling machines to our hospital on the intensive care unit, they came round to actually train the staff about the equipment. And as they were speaking to her, they realized she knew more, was more technically skilled than they were, and they recruited her. So suddenly, our system lost a really good intensive care nurse to the company that was selling intensive care equipment to her hospital because she was so valued. And she felt valued by the company, both in terms of salary, terms and conditions, and just the way they engaged with her. Those are three very key elements that we have to think of in terms of recruitment. There are other things that we need to think about, and I've listed 4 of them there. People need to feel that they're involved in what's being offered to them. It's no good us just producing stuff and then saying, there it is for you. Now you engage with it. They need to feel, well, what's the relevance to me personally in relation? Well, how have you engaged with me to discuss what you're asking me to learn about? How am I consulted? Rarely consulted in relation to what's on offer. The value proposition is, why is it relevant to me? I've been doing this job now. Why should I learn these new skills? Yeah. Insufficiency in relation to CPD. A lot of the programs that we put on offer are voluntary. And if you're very tired at the end of the day, why would you do something that is voluntary? I wouldn't, frankly. I really wouldn't. You know, I come at the end of the day, what I want is a gin and tonic. I want to sit on the sofa and I want to watch the telly. The last thing I want to do is go to a laptop or a desktop and engage in more learning. So there has to be some other way of persuading people to do certain things that we need them to do. And for me, that is a regulatory requirement. There are certain things that if there's not a requirement to do, you just won't do. So it's actually about, well, how do we engage with the regulators about making some key things that we require people to upskill in as a requirement for maintaining their registration. And I know people don't like that idea, that we have to sometimes use a bit of force. But you know, in society, we do it all the time. People have to go to work to pay the mortgage. We don't think of that as a societal requirement, but it is one of the reasons why we have to go to work, pay our bills. You know, if we didn't have to do those things, would we really work the way that we do. There are social requirements that we do to make people do things. And this is one of them. If we're looking at some very key things to protect the system, for me, that is clearly about safety. And if it's about safety, it should be a regulatory requirement. Now, we've had, and you'll hear this afternoon, we've had discussions with regulators about that, and there is a resistance to it. So if that's to change, that has to come at the EU level. The EU needs to grasp some of these nettles and give the lead on some of these things and persuade member states that this is really important for the defense of the health services. And the last thing is our management of our services. One of the interesting results of our survey was the number of respondents who felt that their organizations, whilst they talked the talk around digital technology, actually weren't really committed to it. So it's really about how do we get our management more engaged with beyond rhetoric in relation to these things. So I've hinted at what I think from my involvement in DDS-MAP, what we should do. So this is John Wells's view. It's not DDS-MAP's view, and we haven't come to a collective view yet, but I thought I needed to put something about what I think are the things forward. The first is our training is not keeping pace with the technology. So how do we need to really think, how do we do that? We've got very limited cross-disciplinary training. So we do a lot of training in silos, but actually in the real world, the technology is engaged with by many, many people. So the same platform being used by many, many different disciplines. And they need to have a shared understanding and a shared experience of training. So how do we do that? We've got very fragmented national approaches to cybersecurity. And again, I think that was one of the findings in DDS-MAP. Even our very best cybersecurity at national level training isn't really, it's still in the minority. It's not really meeting the needs of the moment. And this is a moment that we need to meet because the threat is so severe. So, EU for Health initiatives. Crisis preparedness has to recognize there is a reality that goes beyond COVID. It's not just about pandemics. It's about how we prepare and make our health services aware that we're now in a very different political context. And if we like it or not, we are fighting a low-level war through the internet. And our services are being deliberately targeted. So how do we prepare our healthcare workers in relation to that crisis that we need to address? There is another crisis which we have to think about. It's not a nice one to have to think about. But if you look at what has been happening physically to healthcare workers, how they are deliberately targeted, how they are murdered, particularly in a workforce that is becoming increasingly feminine, there is an extra element to that, genderized violence. And that's a reality that we will increasingly have to confront. And of course, in some countries, they are now confronting. And of course, the shock of that, the preparation is everything for these things in terms of people's recovery. So we do have to think about that now in a way we didn't have to think about 5 years ago. We need the European Health Union to be made a reality. So we've got the policy, we've got the rhetoric, but now how do we make that real? How do we make healthcare workers aware of it? What is the messaging that we need? You know, one of the things that we learned through COVID was the power of disinformation. I'm not aware of what we're doing at a European level in terms of the agencies we're setting up who are doing great work, but what is their messaging to the public? I'm not aware of it. Certainly where I'm sitting in Ireland, I'm not aware, if I was to look at the television, what the European Health Union is up to, but I can tell you there's an old phrase, nature abhors a vacuum. It's an information vacuum. And where people are going to get their information about the conspiracy of the European Health Union is through Instagram and is through YouTube and is through the algorithm. So what is the EU doing in relation to the messaging to the public about increasing trust around the European Health Union? And lastly, the EU health data space. I think that's really key. Now, what we've been focusing on is health data and improving of the health services amongst the disciplines and so on. So again, I want to see the EU out there telling the public about their health data and what they can access, and doing some real Europe-wide messaging around that. So I've spoken far too much. This is my problem. Once I get that in front of me, I can't help myself. So I'm going to stop. Thank you very much. And I'm going to ask, I think it's Dominika. You are next. So I do hope you enjoy our speakers and what they have to say. Thank you. Oh, yes. Yes, do. Sorry.
So, welcome to everyone. I got the opportunity and I'm really honored to present our DDS-MAP models that I have to say it's an effort of an amazing interdisciplinary group and team of experts, and I'm glad to present it to you. So what I'm going to do what I'm going to speak about in this probably 10 minutes is how we in the DDS-MAP try to develop really meaningful, immersive, flexible, and interactive blended learning experience. We all know that in healthcare systems, digital transformation requires and demands new skills. Yet online learning and online courses often fail, also due to lack of institutional recognition, poor engagement, poor user experiences with the platforms, and also limited interaction. And within DDS-MAP, we try to address these challenges and really prepare some sustainable and meaningful digital upskilling and reskilling for the healthcare professionals. So within our project, we designed models to equip healthcare professionals, both clinical and non-clinical, as was emphasized already, to ensure them with digital skills and knowledge that reflects the evolving demands of modern healthcare systems. And we created these models following several steps. First, we did the literature review, considering also DG Comp 2.2 and all Ireland Digital Health Framework. We also did pan-European survey. We did the mapping of existing courses and offerings, gap analysis, and co-creation workshops. And throughout the process, we also followed EU recommendation for micro-credentials. And then we developed 4 localized models at level 6 of European Qualification Framework, each awarded with 2.5 ECTS, aimed to be finished within 4 to 6 weeks. And the first 3 models are offering generic and also discipline-specific knowledge and skills for our target groups, which are doctors, nurses, and non-clinical professionals as well. Upon the completion of the model, learner gets the certificate and the digital badge, but the official micro-credential issuing depends on the national regulations. So, within our DDC map, we didn't want only to address some essential skills, but we really wanted to prepare our healthcare professionals for the future. So we included topics like artificial intelligence, electronic health records and data protection, cybersecurity, strategic foresight, telehealth solutions, VR and AR, search management, emergency preparedness, and we also want to focus on the well-being of healthcare professionals themselves, their personal well-being and well-being in relation to digital health, and also to support them in developing organizational resilience in the workplace. So as mentioned, we really tried to address the challenges of online learnings. Therefore, we followed the ABC, Random Blended Curriculum Learning Design, that helped us to prepare clear structure, interactive activities, and also to prepare us the blended format that would address different learning styles and different profiles. We also developed learning personas that are, I would say, fictional, but yet evidence and research-informed characteristics of our target groups, the doctors, nurses, and non-clinical staff, that helped us then to prepare more personalized experiences, because we take into consideration their characteristics, motivation, barriers in relation to their learning. We also fully localized not only the content, but also prepared the platforms in national languages, what is really important, not only the content, but also when there is interface that is in national language, then it's easier to navigate through the platform. And what we really aim to do is to deliver content in different formats. We included text, presentations, videos, podcasts, ER, VR-based activities, and not only these activities, but also we tried to address different learning styles. So perhaps we had podcast with transcription, and then we have interactive presentation with downloadable presentation, because we all know we have different preferences when we are learning. And as I said, we offered generic knowledge and skills, and also discipline-specific deep dives, so that person could really choose what are the areas that really want to learn more. Okay. So what is also important is how you prepare the platform for the learning, and we decided to use Moodle, and I believe, and I strongly believe that our platform is really engaging, interactive, and easy to use. It is also mobile friendly, so that the learner could access on the tablet, on the smartphone, not only on the computer. And as I said, it is in national languages, the whole platform with interface. It includes rich formats, and we also decide to offer offline accesses, so that they could download the materials and study during the commute or in the places without the internet. And what is really important is that we offered support to the learners through peer forums, weekly facilitator emails, and online sessions, so that they got a sense of connection and support. That's really important, so they don't just click and read, that they can really engage with all the materials. So one of the reasons of high dropouts in traditional online learnings is also lack of experiential learning. Therefore, we decided to integrate ER and VR-based activities in our models, in all 4 models, so that learner could practice their decision-making in cybersecurity scenarios. They could use VR for stress management. They could have a tour across the hospital, and also all of the final quizzes within each model were optional in the VR mode so that they could really engage in an immersive way. Okay, I will now share with you our Slovenian experience with the models because we don't have yet the formal evaluation, but what we found that our learners really appreciated is the flexibility so that they can learn with their own pace, so that they can go through some materials really quickly that were familiar and then really focus and read more in depth for those who are new topics. They really appreciated Slovenian interface in the Moodle. This is not always the case. So this really made the difference and eased the navigation through the platform. They also liked that the content was in diverse formats because you really have different learning preferences and styles. We've seen some of them were clicking and some of them were reading that downloadable materials. And also this digital badge and certificate in the end was motivating factor. But what was more important in relation to the dropout was when the institutions and the employer endorsed our DDS-MAP models, when they recognized their completion to the learners through HR or some kind of internal systems, that made the difference within the dropouts. And in Slovenia, we also decided to promote these DDS-MAP models in institutions, in live presentations, and then also helped to onboard interested participants on the Moodle and showcase them the Moodle. So we want to boost the engagement and really persuade them to finish the models. So that's our experience. I know we will talk about path forward later on, but from Slovenian side, we are looking forward to offer these models in the future, and our students express desire to include that in our nursing curricula as well. So that's briefly from my side on the models.
Thank you very much, Dominika, for a beautifully presented presentation. And I'm now going to ask Andreas. We'll have all the questions and things at the end of the presentation. So if you've got a question for Dominika, write it down so you don't forget. I'm now going to ask Andreas de Luga from Germany to talk to us a little bit about the organizational issues, I think, Andreas. Yes. Yes. You can do it. Oh, thanks very much. I'm also going to be Andreas's assistant, and I'm going to click the PowerPoints.
So since I only have one PowerPoint, I will not overburden him. I'm the odd one in this project because I'm the only one who produced tangible results for the end user who is not coming from the medical sector or healthcare sector in wide. My background is business strategy, how to develop your organization. And to give you a little understanding where we come to this kind of complex looking building, I started in 1980 as a freelance consultant to Siemens to redefine business processes. And it was a slow process to understand how the then upcoming digitalization changed your daily work. And it took nearly 15 years before, in the mid-90s, we developed the understanding that we have a strong human factor in business development. And our Esprit project, the pre-runner of today's Horizon, which was called Analysis of Human Factors and Total Quality Management, we started to emphasize much, much more how much the individual worker is the core of the results and not just the worker who follows the concepts. And into the late 9/10s of this century, we focused much, much more on how improving the individual is really improving the organization as a whole. And this is an issue which runs over all industries, not only healthcare. For the last 3 projects we closed over the last five years, which dealt with well-being at work, decent work, stress factor analysis. We always had at least one major pilot user who was a hospital or another healthcare sector. But only one of the previous projects concentrated like this one on the topic of the healthcare sector. So I see myself a little bit as the one who transfers knowledge from all other industry areas to accelerate the improvement we have in one sector. Because that is what benchmarking and the concept of excellence means, learning from someone who has already solved the problem. What is your problem today might be in another industrial sector something they had to solve already 5 years ago. So steal their ideas. They're not patented. Most are happy to share, because at the end, it's about the resilience of Europe as a business market, or even as a civil sector, as the population, which makes us survive the heavy changes we have. So the disruption we see in today's labor market, but also in society, comes from 2 or 3 areas which are overlinking a little bit. One we spoke a lot about is digitalization. But the other, and it's really strange to say something like sustainability is disruptive, it is disruptive by pushing suddenly the effort on it. Just see if you go for the stock market that you have portfolios which focus on green and lean and sustainability, and if you're not in this, you suddenly don't get investors anymore. So all this changed how we think, and we try to reflect this as a part of the support in the module 4 of this training, which helps you to understand how your organization is doing. And we divided the whole thing up into 2 assessment groups. One, we didn't change because that's what we offer anyhow as IBK. Doesn't matter if you come from the Common Assessment Framework or from the EFKM model or from the new Excellence Framework Europe, we have an assessment for this. But this assessment are the experts who help you understand the organization. But you have a real big wealth of information, of knowledge in your workforce, which is not part of this expert group. And how to mine their information is what we try, what we try to do here. They're interested in understanding individually their own well-being, or the decent work conditions, their stress factors, what do they need to improve their continuous professional development. But they don't have much time, so they don't want to run the full assessment. So what we did in DDS-MAP is to combine these things into a consistent, relatively short survey or self-assessment to survey yourself where you are and give you a guideline, but then allow to have an anonymous accumulation of these data on the level of the organization. So the organization starts to understand what are the further development needs I need to address. It's not only the training, it's also, oh yes, we have a not ideal process in this and this step, let's review that process, because that can also change a lot. That's why we presented here also the part which was not developed but is also offered to the users with the lower part of the assessments. So what we do is offer this assessment on the individual level. The results are then accumulated on the level of the organization, and the tool which we provided as part of Module 4 allows each person to act as the team leader for such an assessment, invites other trainees to understand how they can do this accumulation and then see what are the common issues. Where do we have the intervention points which would move us forward the most? And then through this, you select what you want to do as interventions, mostly training in the context of DDS-MAP, but also other changes, and then you measure again. And then you have a continuous improvement cycle over all what you do. And at the end, it's just the questions you have which are focused on in the assessment catalogs, which focus on DDS-MAP. It's something which can drive all type of organizations. And at the end, if you see how you interact from the medical sector to other sectors, one of our projects which is running in parallel is doing the CPD development for engineers around lean and green. Just think of med technology. If they don't work correctly, you don't have new machines, new tools to provide your healthcare services. So yes, you have a direct interaction between engineering sector and medical sector, and that's our job, and that's what we try to bring in. So I'll make it short because John spoke so long.
Thank you, Andreas. And to bring up the most important presentation of the morning, I think, is Frederica, who is involved with the Be Well initiative. And this, I think, is a really significant initiative in providing a framework for a strategy related to the Pact for Skills and its application within the European healthcare. So it's a really significant development. I'm delighted you agreed to come and talk, Frederica. So thank you, and I'm very interested to hear what you have to say.
Well, thank you so much for the invitation. And I feel the pressure now that you've said that that's the most important presentation. I'm not sure if I'm ready for that, but we'll try. So actually, when it comes to the Be Well project, the European Health Management Association is indeed the coordinator of this important project. For today, I'll give a brief introduction about Be Well, but what I actually wanted to focus on today, which I thought it was of interest to you, was some of the preliminary results that we got from the trainings that we are running. Okay, perfect. It's not a very visible slide. I'm really sorry about that. I think that there has been some issues when it comes to the formatting, but it doesn't matter. So how the Be Well project came about, and Petronila has already given a very good framework for it. But clearly, it's to address what are some of the challenges that we're having now in terms of workforce, and specifically the upskilling and reskilling of health and care workers. Now we know that in the we have over 50 million people working in health occupation, and these represent 4% of the European population. So it's quite a large number, although we are facing shortages, but still it remains a big number of the population being involved in occupations, in health occupations. And of course, as we have heard, and as we very well know, and we experience daily, we have the twin transition, so the digital transition, we have the green transition, the need really to focus on sustainability, on green skills. We have an aging population, we have chronic disease, mental health issues, comorbidities, and all of these, of course, impact the health and care workers. So this is how we came up with the Be Well project. The vision of the project is really to prepare the health and care workforce and overall the health and care ecosystem for both the digital and the green transitions. And we want to do that by implementing policies that are applicable at local level, regional level, national level, and European level. Of course, this is through the skill strategy that we are developing. And we do this according to values that include patient-centeredness, but especially for us, the most important thing is collaboration and inclusiveness. The Be Well project is all about building bridges across the sector, involving different organizations, and so on. So the Be Well project is based on a framework, and so the framework foresees the development of a skills strategy, and this is to be implemented at different levels through the Pact for Skills. The skills strategy is available in a first version. Right now, it was launched in June 2023 and is currently under consultation. And so I very much invite you to go to the Be Well project website when a pop-up that is extremely annoying but very effective will just appear with you and force you to fill out the online public consultation. Because what we really want at the end of the project, which is going to be in 1 year, is to have a skill strategy that is really reflective of the needs of the health and care workforce, and not something that someone in an office in Brussels has developed, thinking that it should respond to what we think it's the health and care workers want. And then, of course, as Petronilla has already introduced, we have established a large-scale partnership for the health ecosystem. We have over 50 members. I think they are 54 by the last count, which is great because it really indicates a shared willingness to work together towards upskilling and reskilling of the health and care workforce. And then, of course, we have also developed skills intelligence, both on green and digital skills needs. And based on these skills intelligence, we have developed and implemented a series of pilot trainings, both on digital and green skills and for emerging occupational profiles. Focusing a little bit more on the pilot trainings, what we have been doing is that as I mentioned, we've done a literature review, we've done different focus groups, interviews, and so on, and we came up with competencies matrices. We also, based on these survey health and care professionals across countries, and we got over 600 responses, which really help us develop training courses that were reflective of the real needs of the workforce. Again, this is a fil rouge or leitmotif in our project is really been listening to the health and care workforce other than imagining what they could be needing. And so based on, again, the competencies matrices, the questionnaires, the literature review, and so on, we developed 25 courses. 12 of these are on digital skills, 4 are on green skills, and 9 are on next generation skills, which are the new emerging occupational profiles. And these courses are available on Skills Bank, and we are currently piloting these courses until mid-November, and we are doing pretty well because so far we have already trained 400-ish students and health and care workers. So what I would like to do now is to give you a little bit of the outcomes of what we have learned from these 450 trained students and health and care professionals. So I said 450, and that's the actual number of people that we can track on the platform, but the truth is that we have a little bit less than 300 evaluation questionnaires, so that's why the data may be different from the overall numbers that I gave you. So as you can see here, it's interesting to see that there is a good gender balance in terms of people that have taken the courses, but it's quite interesting to see that the age of the people that are taking the courses are, the majority is under 25, and this is because indeed the majority are students. You see here the colors are not necessarily the best, but over like 150 are students, which is of course one of our target groups, but definitely not our main target group. We also want to reach people that are currently in the profession, not just people that will enter in the profession. What is also interesting here is that we have diversity in terms of what occupation people that are taking the courses cover. So we have a low number in terms of admin staff and management, also healthcare assistants, but especially particularly bad in our preliminary results is the number of doctors that are taking the courses. Of course, again, the 148 other is likely students or people that are not currently in the profession. What is interesting though is that we have 58 nurses or bachelor nurse, and this is because one of our two of our partner organizations are nurses organizations, so there was definitely a push from their side to engage with their members. Another interesting information is, of course, that BeWell covers a number of countries. The trainings are not just in English. They have been translated into Bulgarian, what's the word in English? German is the word in English. So I was thinking Dutch, but it's a different word, apologies. Greek, Italian, Norwegian, Romanian, and of course then we have other nationalities that take courses in English. So this is a total of, we have 140 courses if we look at the translations. Not all courses are translated, but a good majority is translated. And when it comes to the let's say EQF level that are being covered, we go mostly from EQF level 4 to 7, which is indeed our target. Now, another interesting thing is that because Be Well is a project that addresses both digital skills and green skills, and here you can see that the absolute vast majority, with the number seeming 240 something of people took courses on digital skills other than green skills. So this is another important, let's say, thing to think about. And when it comes to the to what trainings they took in terms of digital skills, mostly they took the training on the digital skills for nursing and allied professionals, telehealth. It also has a good number together with Microsoft Office and Google Suite, cybersecurity, telemedicine, and so on and so forth. Of course, we can also see here that the lowest numbers are courses that are a little bit more specialized, for which, of course, we need to do a targeted outreach to ensure that they are taken. And some of these courses are also, and this is important to mention, fairly new, because the last batch of courses for emerging occupational profiles was just launched mid-May. So they have not been available for a long time. So this is just a, let's say, a screenshot of something that is partial, of course, as a result. And when it comes to green skills, here it's a little bit more balanced, but again, it's just 46 questionnaires that we are collected. And so we have, again, green skills for frontline nurses and allied professionals, pollution and health, and then green skills and health sector and health systems and environmental health. And so with these, I just wanted to share a few of what I believe are some of the lessons learned from our side, and I'm very pleased to see that they align very much with the different lessons learned that we have heard from the other panelists. So clearly we see that students are more likely to engage in trainings, and these of course may be because that's what they do, that's their profession at the moment. So there is this familiarity with studying and learning something new. It could also be definitely time availability, which has to be considered to be very limited for health and care professionals. So these, of course, it's something that we need to take into account, because again, they want to probably finish their workday and just relax, and not necessarily engage in something that takes away their time with their personal lives. What we have seen working and working quite well when it comes to Be Well is that networks and local contacts are really fundamental to encourage participation in trainings. I was mentioning before two of our partners, IFN, International Federation of Nurses, and ESNO, the Specialist Nurses Organization. They were really crucial in terms of connecting us with the nursing profession and really pushing their members to participate. And we have seen these in different countries. We have a great example of Italy, where we have very strong partners. They really engage with their students. They really engage with local health authorities and really push the numbers up in terms of piloting. So it's really important to have some allies in the country or wherever it is that the training is being implemented. Equally important to identify champions. If we have one or more professionals that engage in the training and then can, in a sense, recommend the training to their colleagues that works really well, we know that if they find it valuable, then they will speak positively about it, and definitely that's an encouragement for colleagues to participate themselves. And then very much in line with what John was mentioning, really important to secure support within organizations, so from the management side, whether this is in universities for the university system to include certain training within their courses, but especially when it comes to healthcare organizations, very important to have managers to support the training effort of their staff, potentially putting some time aside for them to take courses within their working hours and not having to add onto their already long workday, but also potentially providing incentives of different sort. So that's definitely something that helps and facilitates. Again, it requires a shift in culture to encourage lifelong learning. As I mentioned, of course, students, that's their profession. They study by profession, so that's in a sense easy for them. But professionals, they have a profession, and learning is not necessarily part of their daily routine. So there should be an encouragement towards engaging in lifelong learning, and this should always come from leadership and a vision for the future. And then in our case, because of course we cover both digital and green skills, something that we have noted is that we really need to do more work into building understanding of and interest in what green skills are. Of course, we all appreciate the concept of sustainability and greening practices, but it's not necessarily as easy to apply and to convey to a healthcare professional. So it's quite important to continue working on what is green skills and really make these part of the culture and within health and care organizations. So that's it from me. I very much invite you to go to bewell-project.eu, where again you get this pop-up that will force you to respond to our consultation. This is very important because this consultation is not about what Emma thinks and what some of the BWell partner thinks, but it's really about what everyone in the health and care workforce think. And it's not just about the health and care professional, but it's also about researchers, universities, and everyone that is part of the health and care ecosystem. Thank you so much.
Well, thank you, Federica, for that. For me, the really important thing about BeWell is that you foregrounded Pact for Skills within the healthcare ecosystem. And it's really very surprising, actually, the number of people working within healthcare who never really consider Pact for Skills. So it's just you've had an impact already in the context of changing that conversation, and more power to your elbow, as they say in that regard. So we're now into the question and answer session, and I just want to consult with my technical consultant Omar in relation to this. So are we also going to be using this thing I've never heard of before, Omar, called the Mentimeter questions as well? Yeah?
Yes.
Okay, so a Mentimeter, as I understand it, that is for our online audience to engage.
Both online and offline, everyone can participate.
Okay, so you can use it through your own mobile device here as well. So, you know, as they say, you're never too old to learn, are you? So I've now learnt about Mentimeter, so thank you very much. So I'm opening it to the floor and to our online audience in relation to any questions. Florian is holding a mic, so he will be engaging with anyone who wishes to pose a question. And from my stress levels, I would very much appreciate an opening question, because that will help me manage my own stress in relation to this session. So, has anyone got any questions? Chloe, I see that you seem to have a question. So, Florian, come up. Chloe has a question.
John, we will take the live questions afterwards. We
after
finish
the
the
Mentimeter.
Mentimeter.
Oh, right.
Yes.
Okay. I didn't realize that. So
We
it's
have
just
5
slave coding.
questions in the Mentimeter. We will see 5 questions in the Mentimeter. So if you
Right. Okay.
if you scan this QR code, you will be able to join the Mentimeter.
Right.
You can also go to menti.com and insert this code, and I will turn on 5 questions one by one, and we'll be able to see the answer as well, one by
Okay.
one.
Right. Marvelous. And how long will that take, Omar?
I am also sharing the screen with our online participants. We have 32 online participants listening to us.
Also, I hope Petronilla doesn't mind, but we slightly tweaked our questions based on her slides. What was interesting too was that for a lot of the questions, we already had very similar similar topics identified. We just tweaked them slightly based on the slides. What one skill do you think is the most important for future healthcare professionals? So if you could please put down the word.
Now, do we answer that now?
Yeah.
Right. Okay. So just so that I'm getting into the vibe, as they say, who would like to answer that first question?
Everyone answers it. So if you can go on menti.com.
Oh, this is a survey.
Yeah.
Ah, right. Okay. Gosh, I really am being educated. Aha. So we get this
3297.
Right.
If you go on menti.com, mentimeter.com, isn't it? Menti.com. 35279935. 3527. So that word cloud is from all people answering. So when you put in a word, it'll pop up. So we have emotional intelligence coming up regularly, communication, empathy, leadership, digital, resilience. Emotional intelligence. We'll move on to the next question unless anyone wants the last minute or last few seconds. Oh yeah. On a scale of 1 to 5, how ready do you think the European healthcare workforce is to meet these challenges? Language and cultural barriers, digital transformation and technology adoption, difficult working conditions, recruitment challenges, and aging of health workforce. Language and cultural barriers and digital transformation are hand in hand. It's like a race. Difficult working conditions creeping up. Surprising that aging of health workforce is falling behind. Oh yeah, it's the lower. Yeah. So it's the highest winning in the lowest. Yeah. The high language and cultural barriers is the highest that we're ready for, while aging is the lowest. Followed by recruitment challenges and difficult working conditions. We'll move on to the next question. Which of these areas do you feel that we need the most upskilling support? Digital tools in healthcare, patient care and data, soft skills and communication, elderly and disability care, privacy and security, for example, cyber attacks. Digital tools in healthcare winning at the moment. Slowly creeping up the privacy. But none for elderly and disability care at the moment. Which of these areas do you feel the need for the most upskilling support? Digital tools in healthcare winning with privacy and security a close second. Right. We'll move to the next question. What advice would you give to a new professional joining the healthcare workforce in Europe? Are you answering, John? Establish humility, personal well-being, good practices, learn to manage your stress. So that's second come up. Be open to change. Be open to openness being a big one too. Be open to continuous learning. You are valued. Task management. Join your union. Take a lifelong learning approach. Be empathic and put yourself in the patient's shoes. Work-life balance. Keep upskilling. They should upskill and adapt to the changing work environment. Resilience. Practice again. Competency. Be proud of your profession. Stress management and emotional stability. Continue to learn and be, continue to learn and be flexible and resilient. Continued learning and adaptable. It's a lot of continued learning, practice, well-being. Be prepared for LLL, learn to manage stress, be a caring person. Be ready to work hard. Be smart, be curious, read articles, remember to study during your career, be gentle with patients, work to develop your soft skills and empathy with the patients. Remember that your job is caring. Be yourself and grow, and practical situations could differ through theory. Okay. Next slide. Oh, that's it. We're finished on that. So we'll take the online questions now, and then we'll move to the audience. Dominique Delaporte asks, what is the place of natural and traditional care sector? Or Dominique, could you open your mic and ask the question if you'd like?
We didn't quite hear the question, so if you could just repeat it, but a little bit more slowly.
We're just asking Dominique Delaporte, who's asked a few questions, to open his mic and ask those questions at the moment. Can you hear us, Dominique? Can you open your mic and ask that question, or the questions that you have, please?
Yes, I am here. Thank you so much for the question. You and would like to know, because I am representing from EU and international natural care, and I would like to know what is the place inside the map of the digital in the digital map, yes, the data map you present today.
Yeah, are you asking for a digital marketplace where we can find courses like this?
Yes, that's right. And maybe the place of the sector that we represent in a Be Well project and in a Pact for Skills too.
Okay, there are lots of online courses available from different projects. So she's asking, is there any marketplace where everyone can go and find the courses?
So Dominique, thank you so much for your question. The Be Well project has developed a tool that is called the Skills Monitor, and it's on the Be Well website. So it's bewell-project.eu, and the Skills Monitor collects around 100+ courses in this very moment, both on green and digital skills from across Europe. It is a completely free tool, and there are different courses that can be either university courses or one single workshop or online, in-person, blended learning. They could be free or for payment. So there are a lot of different combination. We also specify in what language they are given. And so I think that that's a good resource for you to go and explore and browse. And of course, to all of those who are here and also those that are present online, we always welcome the opportunity to add courses to the Skills Monitor. So please do submit courses in either digital green skills that can be showcased in this platform.
Yes, thank you so much, because we're working as experts for the sector, and we would like to join and to share our experience too.
Thank you very much. The next question is for Dominique.
Florian, Andreas would like to add something.
It is a problem we have also identified, that you're thinking, not you personally, but sector is thinking too much in sector issues here. We have just started another project where all the members are NGOs, which try to analyze what kind of CPDs for professional development are available, which of them are free, over several countries in Europe, and try to make a database for you to identify it. Because a lot of these things are quite often not sector bound. Like I said in my presentation, there are organizational issues in any hospital and any healthcare provider where you might find the answers from some training which was developed under a program for engineers or for managers in general. So this overview is still missing on the market, and we will hope to solve it in the next 2 years. And all the projects are invited then to have that link as a sort of background database.
Thank you, Andreas. The next question is from Fasikas Nora from the HPAS project. So Fasikas, could you please open your mic and ask that question?
Yes, hello. Thank you very much for the presentations. My question is for Dominika. I was super delighted to see that our HPAS projects training and your training project is like a super similar vision and also solutions. So I think we are really building together with the two trainings towards the same direction. And I was wondering, I wasn't quite sure if your training, your pilots were entirely asynchronous, or were there some synchronous parts as well? And the second part of my question is whether you have some practical suggestions for us to improve online training retention for health and care professionals based on your experiences with the DDS-MAP, because our experience is that online training dropouts are usually around 40-50%, even if the training is accredited or if the feedbacks are really great, so when they find the training extremely useful. So I was wondering if you have some words of wisdom for us about this. I would really appreciate it. Thank you.
Yeah, thank you for the question. We had blended learning format, so we had both approaches and I will not repeat that 2 words in English because I will have difficulties. We have online sessions and online support, and they were also recorded. And then for those who were not able to join on these online lectures, that could then revisit later. So we combined both approaches. And the second is really, I think, a good question and difficult question, how to attract learners. It has to be simple. You don't have, you shouldn't overburden them. It is really important that also the institution and the employer dedicate some time within their working hours to allow them to engage with the materials and to really endorse the training within their own system, so that recognize their completion. That is really important. But it has to be also engaging for the learner. So it's just, so that learner is not just passive. When you have a lot of material to read, it's really difficult for us, not even for the burden healthcare profession. So it has to be simple and interactive and optional to dive in what interests you and really skim quickly what you already know. That's some of the ideas, but I think John can add.
So in relation to
the idea how to...
yeah. Couple of things that I would, in relation to that. So one of the things that we put into DDS-MAP was virtual reality, because it's sexy. And, you know, people but actually there's a practical difficulty with virtual reality. It's the hard technology. So whilst we were offering the VR, it's based on a very clunky headset. And the only way that you can engage with the clunky headset is to leave the clinical area and come to a venue and put it on, and then it's marvelous. But there's the practicality that people can't do that. So we can sometimes get a little bit over enthusiastic about the technology without thinking through some of the practicalities. So until we can get a really, what I would suggest, you know, light mobile phone that engage with VR, that you can slot into something and engage that way, you've really got to think very carefully in terms of using VR. Very easy if you've got students who are on a full-time course and therefore they're a captive and you can provide a classroom. But if you're trying to appeal to people working in the clinical area, and that's actually what we're really focused on in DDS-MAP, it really is people who've formally qualified, they're working out in the environment, and we want them to engage in upskilling and training. You need to really think carefully about the practicalities of virtual reality as an approach. It's very attractive, it's very sexy, but there are some real difficulties with it when you're dealing with the workforce. And the other bit, just to follow up with what Dominika is saying about commitment and so on, you've got to also think about how you appeal to the employer into relation to what you're offering. So the more that you can integrate the training into the normal working day, where both the employee and the employer can train whilst in work, that actually, I think, is key. People are not as willing as they used to be to leave work to go to college for an hour or two. They will do it for an entire semester, but they won't do it for an hour or two. And the employer, who is challenged in delivering a service, is less and less willing to release people for large chunks of learning. So I think it's making it attractive to both, and that for me means integrating training into the normal working day. Would you like to say anything, Frederick? No.
I was going to say too, having an instructional designer on the course was fantastic, just in terms of making it multimodal and the whole pedagogical process, and having those reminder emails and we had a whole plan for the reminder emails, which was a bit difficult in one sense, in that some people wanted to do multiple courses at the same time, and they were all running in parallel. So if you were doing all 4 courses, you would have been hit with a lot of emails. So if we, in an ideal world, we might have done them sequentially rather than in parallel. And Nora also says, yes, we have similar challenges with VR. Also, openness, curiosity for the technology is still something to work on. So we'll move to Dominique Delaporte has 2 other questions. What's the place of green care inside DDS-MAP? And what about a guide of good practices for all sectors and links together skills? That links together skills.
Okay, so ask the first question first, Florian.
What's the place of green care in the DDS-MAP modules? So we do discuss climate change in the context of current and emerging challenges, but what's the
Okay, so one of the in relation to that, really, it's the challenges posed by climate change and what that means for healthcare services. So the first thing, of course, is thinking about it in terms of dealing with new diseases that we're not used to dealing with in Europe. Zoonotic transfer is a common. I think the first time people became aware actually of the potential of the word zoonotic was during COVID. I think most healthcare workers, if you'd asked them before COVID what was zoonotic, they would think it's going to the zoo. So that was the first thing, and that now is becoming as a consequence of climate change, something that we have to think about in terms of educating healthcare workers. And of course, the other thing is climate-related diseases, rises, for example, in respiratory illnesses because of climate change, heat-related illnesses in terms of climate change. And certainly, we thought we had a little bit of a longer lead-in relation to those challenges in Europe, but in fact, climate change, if anything, is speeding up, and our predictive models have predicted a slower pace of change than in fact is the reality. So we're probably confronting some very significant heat-related illnesses becoming more widespread in the next 10 to 15 years. So what are we doing in terms of upskilling? That we've got that within DDS-MAP in terms of the surge management module that will be able to accommodate some of those challenges, but it needs to become more widespread in terms of curriculum. I think curriculum development in terms of thinking about these things and what that means in terms of broader training for the health services. And what was the second question?
A guide of good. What about a guide of good practices for all the sectors, which links together skills?
Which brings together?
Which links together skills.
Oh, right. So one of the challenges, I think, is getting a transdisciplinary training where you have the different groups all in learning at the same time in the same skill set. So, for example, one of the things, and it was a challenge also in DDS, but one of the things Frederica pointed out, one medic. And we had a similar challenge, with all due respect to our doctor colleagues, they are a very difficult group to engage outside of their silo. So, and they need to. They work in multidisciplinary, transdisciplinary environments. So they really need to start thinking about how they engage with those groups in terms of their training. Not just when they're undergraduates, but postgraduate. I think that's one of the real challenges. The other challenge, I think, is that we have to start thinking and talking about the healthcare workforce. And that is more than just the clinicians. The clinicians are very, very key, very important. You do want to be treated by somebody who's clinically skilled. But there are other people around you involved in that delivery, porters, administrative staff, people who man the car parks, they're important too if we're going to get actually a satisfactory experience of healthcare work. And they interact with many devices that everybody else interacts with. They use, they're in the system, they are a group, they are groups who need training and are often neglected in terms of that training. So it's really about us thinking more widely outside of our own silos in terms of that we are an integrated system of workers all dedicated to the delivery of healthcare to the public, and that's everybody. And how we get all those disparate groups together under having a common language, a common way of engaging, that's a real challenge, I think. Easy in the silos, but it's how we break down those silos in relation to training that's the real challenge. Andreas wants to also say something.
Because this is exactly what we addressed with one or two of our new projects which just started. We're in a strange year for us, for my company, because we are closing 2 projects and 2 other ones are starting overlapping. I hate to have more than 2 projects running parallel to concentrate on the factor. But what we identified is that last year there started an initiative, the Excellence Framework Europe, who tries to rebuild the concepts of business excellence as an orientation framework, as an open source concept. So everyone can contribute. Once per year it's frozen to allow the National Excellence Awards, and then it's reopened again and everyone can contribute it again. And if we use this kind of framework to identify improvement possibilities for each organization and mapping skills against them, then we have a sort of dynamic catalog which improves from year to year to understand where we are going. But like I said, one of the projects is just collecting the information about this. It's a very small one, a small scale project, only running 18 months. So next year summer we'll have the results, and hopefully based on this then we will be able to develop that information center, that one-stop shop, however you want to call it, in collaboration with the different national agencies who run the National Quality Awards or Excellence Awards, because that's their main interest, to understand how business in Europe is developing, how we are driving our own market chance competitively against other continents, how to improve resilience of our economy. And as long as we cooperate with these organizations, we might be able to have a good result to summarize this. But it's an open issue. Something new is developed every time. AI changed everything, and it's only 2 years now in the market. So just think of leadership. Leadership in the future will be your personality, how you drive your vision, that people understand you, and the rest the AI does for you. The operational skills, which were important for a manager, will perhaps completely be taken over by an AI agent the next 2 or 3 years. So yes, we understand this question very much, but there is not existing solution yet, but there are several projects which run in that direction.
Janella.
Yes, thank you so much for the presentations and the interesting panel discussion. I actually want to follow up on this dissemination, which is really important. So I wanted to ask both BeWell and DDS-MAP, what was your strategy to reach out as far as possible and as deep as possible in the healthcare sector? And following up on the question from Dominika, you highlighted leadership. So have you targeted specifically leaders in specific areas? And do you already have a bit of an idea of how your courses are doing in terms of outreach? And then I want to bounce back that question you asked earlier, actually, because I think this is a really challenging one, is how do you make sure to keep your courses up to date? Because as things are moving very fast, what are ways that you, or what how have you tried to deal with that? And then just a short side comment is, as I mentioned earlier, under the serious cross-border threats to health regulation, there is in health for the first time a regulation, which is Article 14, which says that there needs to be mandatory, or that the EU needs to organize a training for serious threats to health. So there is actually an EU prevention, preparedness and response training course, which works also on heat waves and different elements. I don't know at the moment at which stage they are. I know that they are already offering workshops and trainings directly involving ministries of health and national institutes of public health. But I think they're also going to publish very soon online courses which can be followed by general health professionals. Thank you.
So if I answer the first question, then I'm going to leave Dominika to answer all the others. In terms of that strategy, and you come up with the strategy, you adapt it, obviously, but how successful you think the strategy is, really you only have to reflect on towards the end. So the strategy was really two pillars. One, professional networks. So engaging with the professional networks of the different disciplines in each of the participating jurisdictions and using those as our way of advertising our existence and what we were trying to do. And the other was engagement through media, national media. And some were much better, whether that reflected their skill set or whether it was just media interest than others in relation to that. So some countries, actually, one of the ones that really surprised me that seemed to get very, very engaged with DDS-MAP, particularly in the early days in terms of national profiling, was Poland, actually, which really got very high profiling in the early stages of the project. But those were the two strategies that we pursued to advertise the existence to the target groups. I think one area that we I had to take a little time out of DDS-MAP because of ill health, but one of the areas that I would, if I was starting again, that I'd write in would be all the unions. Someone said, join your union. And actually, I think when I think about it now, the unions would be the real way to go in terms of hitting the widest possible number of people working in the healthcare sector, because most people are in a union of some sort, but not everyone is in a professional association. So that would be, for me, if I was rewriting that strategy again, that would be a group that I would really foreground in terms of engaging. So, Dominika, do you want to answer some of the other questions?
Yeah, the leadership was the second one. Yeah, we decided to, in Slovenia, to approach National Public Health Institute, and also we scheduled in-person visits within hospitals and other healthcare centers to present the leaders and the management our models, to showcase them the Moodle, the content that we are offering, and they also invite usually the leaders from other units. And afterwards, we also scheduled the presentations for the interested learners. So that was really first approaching to the leadership and showcase them what is the benefit if their employees join. And that was really I think, the most effective way.
I would like to answer your question with a counter question. When is the Commission prepared to review and change a little bit, not much, but a little bit, these ideas of project results have to be free? Because it's a question of sustainability. Who pays for the further advancement of the product? If you have a university partner, they will be happy to do it for the internal training, but only the internal training. No university has the budget to keep on developing the stuff for another university, another country. And for those partners who are in as a commercial partner, we also need some money. We have, for example, the philosophy that the project results themselves only have a small maintenance fee, but we need that maintenance fee if you go for the organizational result. The individual I can make for free, but if I have an organization who wants to run it, I must install a special project for them to be sure that the data stays in the company and anonymous. Must be paid for. I can give you one example from a recent project we did together. We had 2 assessments in this project. One was on the organizational level from us, and I refused to produce anything for a smartphone app. We do it for a browser, and optimized for smartphone use. The other product was done as a standard app with an app store. 3 years after the project ends, all the app stores suddenly demanded, oh, we need to have it recertified. And please, for each language group, because app shops are national, who is paying for that money? Because no one is earning with it. So all the partners said, no, sorry, we can't do it. The thing disappears. So if this is not reflected, the sustainability of project result is a little bit weaker than it could be, because no one asked to earn millions with this. It's just to cover the costs of maintaining them. If you want to earn money, offer services around it. That's where the money should come from. But the results themselves must be allowed after the end of the project to earn enough to support sustainability. Then it's more easy to keep it alive.
I just wanted to say too, some of the modules are still ongoing, and there is another cohort that is going to be done. But at the moment, it's around 1,600 that have enrolled, and close to 700 that have done the pre-questionnaire. But we obviously have to see once everything's finished, how many have done the post-questionnaire, and then how many certifications have been issued to. Yep.
Petrina, I have a feeling we didn't answer one of your questions. What was the? No? Okay. Oh, yes.
I think Chloe was waiting for a while, I think.
Yeah.
Yeah, what time's lunch? No, thank you. That was great. At least I had a bit of time to think because we went online there. But I was just thinking in terms of the leadership, I guess, that you were just speaking about there. And the first presentation this morning was saying that aging and the workforce is obviously one of the big challenges. And then I think, Federica, you said that the lowest number of people that engaged with the course were 55 and over. And I think it's just an interesting thing to think about how you diffuse change within organizations when I guess the older or the senior staff generally hold a lot of that kind of influence around diffusion. So I don't know how, the strategy for engaging that population then maybe has an impact, but that's on the spot anyway.
I think that's a really important point, actually, what you're saying. If you profile the health, there's two things actually that struck me in relation to as Federica was presenting the results of Be Well. One was when you said about gender balance, actually it's gender imbalance, because the majority of people are women. So when we say we're getting close to 50-50, actually that's really worrying, because it means we're not engaging with the majority of people who work within the healthcare system. It's roughly 80% women, 20% men. And we have to think about that. What is putting women off engaging with the training as opposed to the men? Men love tech, by the way. That's one of the reasons why they engage with anything that's techy. It's the new macho, you know. But it really is something we need to think about, how we engage the majority of the workforce in training, what's putting them off engaging. The age profile is also, look, I'm part of that age demographic. I mean, it is becoming an increasing challenge in terms of how you engage with that demographic. And frankly, we need them to work longer. Because we're just not recruiting enough young people to replace them. So it's a very I haven't got an answer to it, but it's a very significant problem that we really need to think about. There's one thing, because I'm aware of the time now, and there is one thing I've been thinking about over the last year, and it is this term resilience. And we've got, it's everywhere now. And how we build resilience. And it's an important concept, but the problem with it is it has a very passive element to it in terms of, if you think about it, a punch bag is resilient, but it's not proactive in terms of what it has to put up with. So as a concept, I'm moving more towards the notion of regulation, self-regulation, organizational regulation. I think it has a more proactive construct to it, whereas resilience is really, I need to be able to just stand there and take what's being thrown at me and manage that. And regulation, actually, I can be proactive. I can go out and I can change things. So I'm not going to be bashed. I'm not going to have to sit there. So I'm moving much more towards that concept of self-regulation, organizational regulation, rather than resilience. Resilience for me is far too passive as a concept. And I am one of those people that believe that words matter. Words are the way that we express our thoughts, feelings, and behaviors. And it also therefore means that words influence our thoughts, feelings, and behaviors. So I'm moving away from resilience as the core concept to focus on and thinking more in terms of regulation. With that final thought, it's midday, so we're very good. We're keeping to time. So Omar is now going to come and give us the information about the next stage.
First, thank a big round of applause for our panelists for the wonderful session. So now it's time for lunch. The food is already served outside. And I have a good news also for you, because our colleague from ACTU will also set up a small demonstration for the virtual reality. So you can enjoy the lunch and the virtual reality together. And we will come back at 1:30 for the workshop. It's called Pan European Microcredential Framework. And we have a panel of speakers who will join online to share their practices from different countries on the microcredential framework. So thank you and enjoy the lunch and enjoy the VR virtual reality demonstration as well. Thank you. Hello. Hi, Beata. Hello, Martina. Can you hear us?
Yes. Hello.
Yes, we can hear you as well.
I can hear you. Do you hear me too?
Yes, we can hear you very loud and clear. And I hope you can also see me right now, but we will also move the camera throughout the workshop so that you can also see our audience as well. It's such a big crowd here in Brussels. So we will move. Yeah, now you can see.
Yes,
So
thank you.
we are starting the workshop, and thank you so much, everyone. I hope you enjoyed the lunch and the VR demonstration. I hope it was cool. And I hope you can steal some of the VR device from the team or no? To take home and try. Okay. So now for the next 1 hour, we do our workshop, Pan-European Microcredential Framework, a skill recognition pathway for medical and allied professionals. To moderate this workshop, we have the speakers joining online, Professor Beata, also Professor Dr. Martina, and we also have one speaker who is here in Brussels with us, Professor Fiona Timmins with us. So I would like to request Professor Fiona to in the front, taking the seats. Thank you so much. And we have also some video messages that will be played. So, but now without further ado, I hand over to our moderator, Beata, to moderate the whole workshop. Thank you so much, Beata.
Thank you, Omar. Good afternoon, everyone. First of all, I would like to apologize for not being physically in Brussels. This is really a big pity. However, I am from the beginning, from morning session and all the presentations and discussion. It was really, really interesting. As it was said, my name is Beata Dobrowolska. I am one of the project consortium member representing Medical University of Lublin in Poland. And this is really my big pleasure to start this afternoon session regarding micro-credentials. First, let me shortly present the aim of this session. We would like to discuss how pan-European frameworks can support the recognition and accreditation of micro-credentials for medical and allied professionals, with a focus on engaging regulatory bodies and professional associations in promoting microlearning and the validation of digital and data skills within continuing professional development pathways. Of course, all of this will be done framed within the context of DDS-MAP project. It is my great honor and pleasure to shortly introduce our great speakers. So first of all, we are having Dr. Helen Murphy, who sent us a voice message today. She's not present, unfortunately. Helen is a head of Faculty of Education and Lifelong Learning at CETU in Ireland. We also have Dr. Adriano Friganovic, who is president of European Specialist Nurses Organization. Great that Adriano is joined us. Thank you very much. We also have Professor Fiona Timmins, head of school at the School of Nursing, Midwifery and Health Systems, University College Dublin in Ireland, and Professor Martina Smolic, Vice Dean, Science and Postgraduate Studies, University of Osijek, Croatia. So let me share with you some really brief background and vision of the DDS-MAP project when it comes to micro-credentials. From a morning session, you could hear how multi-dimensional DDS-MAP project is still ongoing. And you heard about modules development. John beautifully explained why this project is important and what was the base and the reason for development of this project. One of really important element of this project is also micro-credentials approach. So in this project, we are trying to respond to the growing need for flexible work-integrated learning pathways in the healthcare sector. We are trying to support the European Commission recommendations on micro-credentials. We also aim to enhance CPD by integrating learning into daily work practices. DDS-MAP also is designed to upskill health professionals in digital and data competences through accredited micro-learning and promotes education as a core professional value and fosters long-term qualification development. What is also important, we try to use micro-credentials to engage the learners within their work settings, tailoring content to discipline-specific needs, as it was heard during morning session. We also try to integrate micro-credentials into work-based learning, enable recognition of skills acquisition through small stackable units. plan for micro-credentials implementation across all partner higher education institutions. During the project, we also trying to collaborate with national regional regulators to enable professional recognition and to promote CPD and workforce development across Europe. To hear more about micro-credentials themselves, what it is actually and how we incorporated this approach into DDS-MAP project, I would like to first maybe not invite, but ask for sharing video message from Dr. Helen Murphy.
Thank you, Beata. Can we have the video now on the screen? The video message by Dr. Helen Murphy.
Presentation on our experiences in micro-credentials, and then specifically some of the challenges that we're experiencing we're working on across a number of European projects and institutional projects also on microcreds, and some questions at the end then towards the DDS-MAP. We've been working with John, Florian and all of the DDS team since the start of this project. So I'll go through it, and I'm happy to share the presentation at the end and take any questions that people may have. So in terms of, now some of you, and please forgive me if some of you are well and I think many of you will be well versed in the world of micro-credentials, but you know, I thought putting out a definition there in terms of what we mean, and certainly what's embedded within this particular project. The micro-credential, the definition that we're taking really is that it's proof of the learning outcomes that a learner has acquired following a short learning experience, keyword there being short. So it's a short piece of learning. They are accredited and credit-based, and I'll talk about that process in a little while. The reason we are using them and rolling them out actually across a number of different discipline areas is we're looking to extend access to lifelong learners to very flexible higher education or third level provision. And they're a means for us of responding to accelerated demands. As many of you who are involved in working with universities and so on, it can take a long time to develop a new program, but sometimes, and I'll take AI as an example, we need something quite quick that addresses a very specific need, and I think some of the modules on this DDS-MAP project are also that. They're an accelerated piece of learning for lifelong learners, usually people working in the field. In terms of just some of the characteristics, typically they will have a set of learning outcomes. There will be a workload attached to it, and the type of assessment. And there's multiple modes of assessment, and there's some really interesting assessment being used in this project using virtual reality. In terms of their use, we're currently using them across various different projects to complement a degree program. So we're actually using them on one big European project. It's a European university project, and we're leading out on a suite of micro-credentials that are both for bachelor or undergraduate students, where they can complement, they can do a particular micro-credential on coastal. It's about sustainable development, this particular project, so coastal sustainability and so on. Or they can be standalone, and they can stand alone as per the modules, I think, that are included in this particular project. So just in terms of a history, and again, some of you may well be familiar with this, but for us in Ireland, the concept and notion of micro-credentials is not that new. And that's quite different to some of our European partners, where that whole concept of a short piece of accredited learning is very new, and they haven't had it. Technically in Ireland, we've really had short awards for the last 20 years, and that's post the Bologna Accord, post 1999, when the European higher education system moved towards modularization and semesterization, and the Institutes of Technology were very fast to adopt this more modular mode of delivery. So we've had short awards in Ireland for the last 20 years. However, they weren't called micro-credentials at the time. And the history of micro-credentials has really come through. Many of you will have heard of digital badges, and some of you may be familiar with the Open Badge Factory, etc. Badges were typically non-accredited. So somebody was given a badge. I remember doing one years ago through Allison and Coursera, where there were free badges for a particular short piece of learning, but they weren't aligned to any national framework and they weren't a particular award. By 2015 and up to 2020, there's an increased interest, and this is really being driven by global skills, the need to accelerate skills development, and the need for more accessible types of programs that people can access. And that really led to a European policy position. There was initially a European memorandum on microcreds, and there's a number of European groups working across a number of different member states on how we implement micro-credentials. So they now exist in European policy. That's a copy of the report there that came out in 2020. It hasn't been formally updated, and a lot of the content is still very relevant for us today. But it confirms some of the key principles that I've mentioned, which is a micro-credential is a record. It's a formal record of the learning outcomes that a learner has acquired following a small volume of learning. The learning criteria, so our learning outcomes, need to be very clearly defined. And they are about no more so than any typical module or program that you would come across in higher education. They are about specific knowledge, skills and competences that respond to societal, personal, cultural or labour market needs. They're owned by the learner and they are shared and can be portable. I'll talk about that characteristic in a moment. So all of those principles apply to micro-credentials across Europe at the moment. For anybody who's interested, and I'm not going to go through these in detail, but there is a whole policy framework. And from 2020 onwards, you'll see many of the European policies, and this will relate to health as well as many other fields, will refer to micro-credentials. You will see micro-credentials being referred to as a means usually of upskilling and widening access to professionals working in fields who need to upskill quite quickly, because I suppose the days of us projecting out 3, 5 and 10 years, that's changing, and the skills requirements that we need today, particularly in relation to the twin transitions as they're called, so which is digital and green, we have a need to address these quite quickly. So in terms of the Commission's definition, it's contained in that report that I shared with you. It is also referenced in Ireland through QQI, so I think many of you will be familiar with it. There has been a very large national project in Ireland called the Microcreds Project, which has been led by the Irish Universities Association, the IUA, and again, following a lot of the concepts and characteristics and definitions that are defined in Europe. And then some technological universities are embracing microcreds. So a very quick exercise. So we try and update this table really regularly because we're working across, in education, we're working across a number of maybe 5 or more European projects that involve micro-credentials. And as John said, of the partners and of the institutions involved in this particular project, DDS-MAP, some of them have a framework, others don't. You've mentioned Poland as being one. There are national frameworks, so there is a European policy, but how European policy works is that each national state has to interpret the European policy and put out a national policy. And I believe QQI are going to be reissuing a national policy for micro-credentials sometime during this year. I don't have an exact date, but it's going to come out quite quickly. So that's just to give you an idea of where the different countries are at. And Poland, you'll see that Poland is emergent. So we do have some countries, and as from what I remember, Latvia was the same when we had our meeting last year in Riga. There were some specific kind of pilot initiatives, but there was nothing really available on a national basis. So key aspects for the framework, and as part of this project, we developed a framework, which is a document which was distributed to all of the partners, which says what is a micro-credential in the context of DDS-MAP, which is obviously EU for Health focused. So key aspects, it's going to be aligned to policy. It's based on, there's an agreement that it's based on ECTS, so the European Credit Transfer System. And we recognise anywhere between 1 and, I think it's 30, sorry, I'm moving around my screen here, 1 and 30 ECTS. And we've defined effort hours as 25 effort hours per one ECTS, broadly speaking. Micro-credentials, they should be portable. So what we mean by that is that somebody gets a digitally verified micro-credential that they can add to their CV, that they can share with their employer, that they can share with possibly professional bodies who have a CPD requirement. I think we work a lot with teachers, so there's a requirement there for a number of CPD hours in order to stay registered as a professional on the National Register. They may be stackable, and what that means is that if we had a 10 credit module, it could be divided into 3 micro-credentials and they're stacked on top of each other. I would say that's really in its infancy in terms of how we do this. And verifiable is the digital verification system that's needed to make sure that it is legitimate and that you can see the awarding body and so on. Again, in terms of the key characteristics of the framework, it does define micro-credentials as being there for upskilling or reskilling. They're evidence-based and they are based on a skill or a competence need. And as I reiterate from before, they offer access to non-traditional learners and they're very flexible. I should say that most micro-credentials, if not all, are delivered online or with a very high component of blended learning using technology. The idea being that there's quite a bit of self-directed learning involved for individuals. So from our most recent, and as I said, we dip in and out of this, 14 European countries, that might be 15 or 16 by now, but most of the countries across Europe are in the process of developing a framework for micro-credentials if it's not already in place. Our own involvement, I suppose currently, we started in about 2018, 2019 with this EBSN was a project for VET teachers, as they're called in Europe, so they're further education teachers in Ireland. And that was a series of 6 micro-credentials to upskill teachers across Europe. Excuse me. EU Connexus is our European University Alliance at SETU. And we are developing 20 micro-credentials. And then DDS-MAP, which we're here to talk about today, is a suite of initially 4 micro-credentials for healthcare professionals. Just excuse me one moment. I am recovering from a terrible dose, so please bear with me. So this, for those of you looking for more information, the European definition and policy it gives quite specific guidelines in terms of what needs to be included in a micro-credential. You'll see there everything from key things, awarding body, the learning outcomes, the notional workload that might be involved. And that can be anything from 25 hours if you're talking about one ECTS, up to 100 plus, depending on the number of ECTS involved. So just in terms of certification process, and we've probably been involved in all different models. Some micro-credentials can be developed, and I'm thinking of, and we work with a lot of professional bodies also in education, can be an individual university. We, as SETU, and before that, WIT, developed single micro-credentials that were awarded by the host university, which was ourselves. We've also been involved in and are currently involved in delivery of a group of micro-credentials. So this one, DDS-MAP, is an example here, where you have, at the moment, 2 accrediting universities, but that may extend as you know, if there's a phase 2 of this project. So there's multiple type models out there in terms of issuing micro-credentials. This will give you an example, and it's really just a blueprint, just to give you a sense of what a micro-credential might feel like if you're a learner. And this is based on 1 ECTS, and it's over 8 weeks. So, and you'll see there's an online unit once every 2 weeks. They often involve a combination of video resources, lots of content, but that content, because it's being developed for online delivery, needs to be very interactive and self-explanatory for learners. We usually have some moderated discussion forums, so there's an opportunity for a learner to connect in with a facilitator on the subject. And we do lots of things like quizzes and so on. And sometimes we include a webinar there as well. So there's a variety of content, and it's delivered, some of it on an asynchronous basis, which means that as a learner, I go on and I look at a video, read, or maybe listen to a podcast. But I also have got to attend some live facilitated sessions. So I have an opportunity to engage with my peers and also ask questions and so on. So on the DDS-MAP project, which John and Florian and others are here today to talk about, there's 4 different micro-credentials that have been developed. They're aligned to the level 7 of the National Framework of Qualification, and they're all 2.5 ECTS. So, and I'm sure we have an opportunity to delve into a little bit more detail on that, but that's the existing portfolio, if you like, of micro-credentials that have been developed specifically for medical and allied professionals for this project. So good afternoon again, everybody. I have a short presentation on our experiences in micro-credentials, and then specifically some of the challenges that we're experiencing we're working on across a number of European projects and institutional projects also on microcreds, and some questions at the end then towards the DDS-MAP.
Thank you very much. It was, I think, really briefly explaining what micro-credentials are and how they are incorporated in DDS-MAP project. However, as we heard from Helen's presentations, there is a really big diversity among countries in Europe when it comes to introduction of micro-credentials into nursing or other health care professionals postgraduate education. I think that today's panel, today's workshop should be focused on this. So let me share my screen again because I would like to show the question which will guide our further discussion. And I will give the voice to our speakers. So the question is long, however, divided into some parts. How can European and national policy frameworks, together with professional regulatory bodies, better support the standardization, formal integration, and recognition of micro-credentials within health science education and CPD pathways for healthcare professionals? And having this question now, I would like to give the floor to Dr. Adriano Friganovic.
Hello. I will share my screen. Do you see presentation?
Not yet.
Okay, share. Entire screen, share.
Yes.
Okay, now we will be here. Is it okay now? Well, hello everyone. First of all, thank you, Beata, for inviting me, and to all organizers to prepare this nice program. My name is Adriano, and my today's topic is lifelong learning and continuing professional development in specialist nurses. I'm coming from Zagreb, Croatia, working at University Hospital Zagreb, also working as assistant professor at University of Applied Health Sciences in Zagreb and Faculty of Health Studies in Rijeka, but here I'm a president of the European Specialist Nursing Organization. And what is ESNO? ESNO is an enthusiastic community of nurses in the widest possible variety of specializations, connecting to inspire each other and connect on innovations and make our work beautiful. But what are our primary aims? Our vision and mission is to implement the harmonization of the specialist nursing education across the Europe, not only European Union, but entire Europe, to assure recognition and to assure certification. It seems very easy, but it's a hard job. We just started in the beginning, as well as the micro-credentials will also be very hard to implement and to harmonize around the whole European countries. Other specialist nursing goals are unique and unified. It's to provide best possible care. We want to provide the best standards. We want to assure holistic weight and want to contribute to good systematic approach. But it is hard these days because we all have a shortage of nurses. We are talking about nursing leaving professions, but not many governments do a lot about the issue that improve the working health environment for the nurses and to stop them leaving that profession, because we have a really great profession and people love to be nurses, but it's become a very hard job. And I always want to remind, and we should never forget the time in the COVID pandemic when we were forced to change the positions, forced to go to the other places. We got it applause, and after pandemic was over, applause stopped. And I thought that we didn't catch the momentum. We should, but somehow everyone forget on nurses. And this is what we really want to achieve, to connect nursing in Europe with the clinical reality and EU policies, and to become a bridge between all of this. Because sometimes you have to repeat dozens of times about one topic to politicians hear you and to become area of their interest. What we really want to achieve is to promote the specialist nurses in the formal EU structure. 10 years ago, no one spoke about specialist nursing. Now we become very actual, especially after COVID, because COVID pandemic also showed that specific areas in nursing, such as intensive care, anesthesia, emergency nurses, brings specific knowledge and specific skills. And I cannot be a good psychiatric nurse, but I'm maybe good intensive care nurse. If you send me to psychiatry ward, I cannot provide the best care. We want to contribute to health challenges from the nurse's perspective, act as a full partners and in the interdisciplinary aspects, strengthen the EU health regions by investing in a nurse specialist. And what is really important, we have to promote nurses' well-being across the Europe. And these are the facts from two researchers. One is Nico de Kock and Associates, and another is Cécile Dury. That position of the specialist nurse profession varies across the European Union. We want to achieve harmonization, but we are still quite different. And if we striving for homogeneity in the interpretation of the specialist nurse's role and competences is needed to achieve better quality of care provision and facilitate their mobility around Europe. Whole idea about European Union is mobility. If I finish my education in Croatia, I can go to Poland, I can go to Spain, I can go to Ireland. But somehow, if you finish some specific program, it is not like that. It's really hard to get recognized that programs in the different countries. And what Cécile Dury also concluded, that concept of the specialist nurses has existed for many years and related educational programs are proliferating. But literature clearly outlines the role and practice of registered nurses and advanced practice nurses. Those of specialist nurses remain unclear, and nursing specialization across Europe need clarifying. And in the rapidly evolving landscape of healthcare, specialist nurses face increasing demands of upskilling, reskilling, and professional agility. This is a very well-known topic in the Brussels bubble at the moment. Micro-credentials, short focus qualification certifying specific skills or competencies offers a promising strategy tool to support lifelong learning and continuing professional development for the specialist nurses across the Europe. But we also have to be very careful about all these topics. Micro-credentials provide flexible modular learning pathway that allow nurses to tailor their professional development to specific clinical needs, emerging health challenges, and individual career trajectories. This is particularly vital in the specialist field where rapid scientific advancements and technological innovation require continuous updating of knowledge and skills. But these programs has to be upgraded on the university level of nursing. Some countries, especially I can say mine, we have a dual entry, which is problematic, and it's hardly to define all these programs. How to integrate international and EU level CPD systems. For micro-credentials to become a meaningful component of the continual professional development, they must be embedded with existing national and EU level frameworks. And of course, we are again coming to the good cooperation between all stakeholders. It has to be recognized by regulatory bodies. National nursing councils and regulatory agencies should recognize accredited micro-credentials as a valid contribution to CPD requirements. Digital credential and portability, the use of Europass digital credentials can facilitate cross-border recognition and mobility of specialist nurses. Well, I would say it can, but somehow it's hard sometimes. Stackability, micro-credentials should be designed to stack towards larger qualifications and allowing for coherent educational progressions. And of course, it is really important to promote equity in access to CPD. Online and hybrid delivery modes reduce the need for travel and enable participants regardless of location. Well, that's all really important. Well, it's important for every country, but my country has 1,000 islands, 300 inhabited islands, and there are some nurses who live there. It's really very hard to travel to get some courses. Online and hybrid modes solve this problem. We have to lower financial barriers, shorter duration, targeted content, make micro-credentials more affordable and cost-effective than traditional CPD models. And we have to work on the supporting workforce diversity. Accessible CPD supports retention and advancement of nurses from diverse backgrounds, strengthening the workforce and inclusivity and resilience. To fully realize these benefits, equity considerations must be embedded in the design, delivery, and dissemination of these microcreds. And in conclusion, to realize the full potential of microcredentials, a coordinated effort is needed among policymakers, educational providers, professional bodies, and healthcare institutions. At the end, it's always about cooperation. We cannot work in our own silos, nurses for themselves, doctors for themselves, physiotherapists for themselves. All healthcare stakeholders must work together to achieve these goals. And thank you very much for your attention.
Thank you very much, Adriano. I think you addressed really important issue like mobility of specialist nurses and recognition of their qualifications. Now I'd like to give the floor to Professor Fiona Timmins. We heard from Helen's presentation, but also from my observation. I think that Ireland is really in the top in Europe regarding introducing micro-credentials for very different fields, also for medical and nursing professions. So please, Fiona, the floor is yours now.
thank you so much, Beata, for that wonderful introduction. And Diva Cordia, it's wonderful to be here in Brussels and to see the fulmination of a truly wonderful project. Thanks to each and every one of you and all of those who've contributed across the years to this important work. And of course, huge thanks and congratulations to Professor John Wells, leader, scholar, extraordinaire, friend. Thank you. And thank you for this opportunity to share some of the work that has been done under the auspices of the DDS mapping project in Ireland. So today I'm going to speak a little bit about issues and themes in micro-credentials from the Irish regulators' perspectives. So building on Helen's excellent presentation earlier on, I'm going to briefly outline the outcomes of conversations, if you like, with 7 healthcare regulatory agencies in Ireland, where the focus was on micro-credentialing implementation in healthcare education. So, minor introduction, not to repeat Helen's presentation, but just to place what is our operational definition as such. We've learned this afternoon's presentations that they are small, stackable, accredited courses, anything from 1 to 30 ECTS credits. In relation to the National Framework of Qualifications in Ireland, they're between level 6 and level 9. Quality assured with transparent assessment standards. And thank you, Beata, for those wonderful compliments. Ireland is indeed a wonderful country and leads the way in many things, and we are delighted to be the first European country with a national framework for micro-credentialing, and we're very proud of that. And ultimately, of course, as we know, designed for upskilling, reskilling and career development. A lovely quote there from the Irish Universities Association. You could almost eat them. Micro-credentials provide learning opportunities which offer highly flexible, bite-sized and an accessible way of upskilling and reskilling. So huge commitment in Ireland to this type of learning. Just to outline briefly the current status in Ireland, we have, as Helen mentioned, a national micro-credential project led by the Irish Universities Association. It has 7 partner universities collaborating, and also collaboration with an enterprise advisory group with industry leaders. And there are 4 key deliverable strands. Firstly, a national framework architecture. Secondly, micro-credential innovation through enterprise collaboration. The third strand, a discovery portal for learners and enterprise. And finally, strand 4, a suite of micro-credentials across the university. So the project duration spanned 5 years, project investment 12.3 million, and ultimately then we're the first European country, as I mentioned, with a national framework for micro-credentialing. To outline then the future directions, firstly the key challenges that many of you have picked up from already what I have said. There's an inconsistent approach across regulators. There are identified digital competency gaps, and there's limited European collaboration. Of course, every cloud has a silver lining. We have wonderful opportunities. Ireland's leadership position, the interregulatory cooperation that we experience, and the ability to shape European standards. So our recommendations then are to standardise guidelines, to enhance European collaboration, to focus the national qualification framework level 8-9 rather than lower than that in this particular domain, focus on digital micro-credentials, integration within the continuous professional development frameworks of the various healthcare professions, and a focus on smaller ECTS-based courses. So the next step then is to develop a joint regulatory working group, create digital competency micro-credential module, establish a European regulatory forum, and publish standardized guidelines for implementation. And we just have, thank you Florian, a beautiful slide here that summarizes this very nicely. What are the 3 important things we need to do? Haindó 3, as we say off scale in Ireland. We actually say that before we dance as well, don't we? Haindó 3, let's all start ag dausa, dancing. So to dance forward, We need to align with CPD with clear guidelines. We need digital upskilling, a joint regulatory approach, and we need international standards and a need for this pan-European account, which takes account of the differing educational qualification frameworks requirements between regulatory bodies. Gurmila Magad.
Thank you very much, Fiona. What a beautiful presentation. So we know now which country rely on when it comes to development of micro-credentials across Europe. And to be honest, yes, I can say based on our perspective in Poland and in Lublin, that DDS-MAP was a really great motivation to start introducing micro-credentials at our university, for example. And now I would like to give the floor to Martina Smolic, who I am sure will share with us her experience of introducing micro-credentials also at her university.
Sure. Thank you, Beata. Can you hear me all, or is it?
Yes.
Okay. I'm also sorry that I'm not physically with you in Brussels today, but there were certain difficulties with flying in. So I would just continue.
But only, I'm sorry, Martina, can you make in a presentation mode your slides?
Okay, sorry. You are
not a problem. Thank you.
Пустите презентацию, кликните. Почему?
Sorry. It's this. Is it now in a presentation mode or?
No, but anyhow, it is visible, so don't worry.
Stop share.
Проекции.
Okay. I do have a technical support here, so I'm all professor. See, just.
Martina, maybe you cancel and stop share, and then you share again.
Okay.
Try one more time.
Yeah. Sorry. Share. Okay.
Yes, now it's.
Yes, it's better now.
Right.
Thank you.
Thank you.
Thank you. So sorry for the technical difficulties. So good afternoon to everyone. So I will just briefly try to wrap up this workshop about our experience with micro-credentials in Croatia. As Beata said, DDS-MAP project was really a great introduction to think about micro-credentials more, as we are all involved in developing programs, and you working at your university know how long does it take to standardize, to get accredited for one new program. Then when someone says you develop, a small micro-credential that may be or maybe not be recognized by the students and by the regulatory bodies, you're reluctant to do it. But, with the DDS-MAP, we were actually introduced to this is a great thing and that we should join the train and, try to develop the models that were developed during the project to be recognized as micro-credential at our university. Croatia is below the average of lifelong learners in Europe. Like 56.6% European citizens are taking lifelong programs. Croatia, it's about 30% of all of our citizens are involved in the programs like that. And as you heard before from Helen, the history how the micro-credentials were developed in Europe. The European framework was done in 2020. And then, although we heard about it, but in Croatia, the Ministry of Science and Higher Education started talking about it more in 2023. So few workshops are now going on every single year. And I think by now all the university know about the national framework that is in place right now. Because at the beginning, lack of formal recognition mechanisms with the national legislation was there, and there was a definite need for a standardized quality assurance process, which is now actually going on. So these are the workshops from 2003 that are going on, and all the higher education institutions that are that want to develop micro-credentials now finally know what to do it. So the first thing, so the instructions are developed, and on the national level, and then they are put down to the universities. And how does it work? We need to fulfill all the mandatory parts of the procedures, and as Helen showed you, what all the documents we need to submit it when we are submitting a new micro-credential program. We need to find out once the program is described or developed like our models in DDS-MAP project are. First thing is to be recognized by the university itself, and then submit it to the national agency for science and higher education, which ensures that the program itself is in alliance with the Croatian qualification framework. As Adriano said, at the end, it's really, is it recognized by the people who will really need it, and who would really upskill their working necessities. So the quality program, quality assurance needs to be in place like with the other programs involved, and transparency as well. Voucher system started in Croatia 3 years ago, which is really cool thing. One of the things with the vouchers is because this percentage of our citizens taking lifelong learnings was below the European median. It's that Croatia put 60 million euros into lifelong learning programs. So, and all of us have our own e-citizens accounts, where we can choose the program that we would like to go for free. And so I hope that once the DDS-MAP models that are developed, and once they are accredited as a micro-credential, micro-credentials at our university, that the model would be offered for Croatian citizens for free as well. So definitely, micro-credentials in Croatia offer a valuable opportunity to modernize our higher education system, although we were at the beginning very strict and reluctant to do it. And I think by being part in this DDS-MAP project, we actually realized how great this could be, and that the full potential of the micro-credentials is gonna be in place in Croatia. Thank you for, and I'm sorry for the technical difficulties one more time. And as always, I invite you to Osijek, and I hope we'll see each other soon again.
Thank you very much, Martina. We can see now, we heard very different voices regarding introduction of micro-credentials into national systems of education, not only heard healthcare professionals, but generally. And despite the European recommendations from 2020, we still have very diverse levels of implementation of micro-credentials. I think that now we can give a voice to our audience and start a discussion. If you have any questions, please, you are more than welcome to ask. We know that there are very many challenges, sometimes barriers regarding implementation of micro-credentials into national systems of CPD, from financial issues to law regulations, barriers
Professor Will?
also.
I have a question, Beata. The real problem that I've learned through the DDS-MAP project in relation to micros is that no one can agree on what one is, and that's a real barrier. It seems very contradictory. If you think about mobility of the workforce as being a policy goal of the European Union, in term, and all the work that's been done, for example, through the Bologna process, that we can't seem to get together at a European level and come to an agreement about what a micro-credential is. What it actually, now for me, the clue is in the word micro, but people seem to have a very broad interpretation of micro means. So a very first building block would actually be for the Commission to set up a working group to actually define what a micro-credential is, rather than trying to leave it to member states who even internally can't agree amongst themselves between different institutions what a micro-credential really is. So, and Fiona's pointed this out just in terms of the levels and differentiating levels and how that should be done. So for me, that's a key aspect. We need greater guidance at a European level, first of all, if it's to be a successful policy in terms of underpinning short periods of training and upskilling. So for me, that's a very key aspect that needs to be addressed.
Yes, thank you, John. I think that this is really an issue because when we started discussion among our healthcare professionals regarding micro-credentials approach and idea, the first question which we heard was, okay, but what is the difference between micro-credentials and other courses which are available in the field of postgraduate education, for example, for nurses or physicians? So to give a really clear definition what is micro-credential would be really important. Dear speakers, do you want to address this issue also in some way? Adriano, please.
Well, I think, as I said in my presentation, it's really hard to make the unique definition because every country, not only every country, different people in the same country redefine. And yes, what is micro? We have to be specific and clear and give an input to the Brussels and to legislation, to regulators, to implement across the European Union. I think that's the main goal we have to achieve. Because, well, sizes are over, micro means different to other people.
Yes. Any other issues, questions?
Yes, one. And mainly to Fiona, but also to the others, because you mentioned also this micro issue that smaller units are more digestible. Did you consider to also close your groups with other areas than healthcare, because being a management consultant and coach and trainer for long years, I know it's very hard to sell anything which is beyond what we here have defined as one ECTS. One ECTS means you have 3 to 4 afternoons plus homework for your trainees, and it's delivered all within the self-month, or you have 2 weeks and homework in between. That is sellable. Anything above that, forget it. Because then the top managers would say, I cannot have this kind of commitment of my people. I don't know if I wouldn't need them in the next 2 weeks to do something else because something urgent pops up. So if we can have a general approach independent from healthcare sector for this, might make your life more easy, because all professions who have a CPD approach, and that is nearly all of them, have the same issue.
Yes, fabulous point, and Andreas, and an observation. Thank you so much. And I think you're absolutely right. As I think Andriano, and hello Andriano, good to see you again. I think you mentioned about silos. It's very important not to work in silos. And your wonderful presentation this morning yourself, Andreas, highlighting that we're more similar than we are different, and that, you know, why reinvent the wheel if another profession have done and managed challenges that we are already facing. Let's share. So I think possibly it was, we have to manage things ourselves in bite-sized chunks. So the scope of this project was huge, and I suppose it had to have a particular focus. But I think it's something for DDS going forward. And it was wonderful to see Helen's presentation this morning, because she's obviously embracing multiple disciplines. So I think the fact that Ireland, I said it already, is leading the way. Maybe we have that opportunity, and it's a small country as well. And even though there are lots of, you know, differences across various elements of that, leaders like Professor Wells and Helen this morning, Dr. Murphy, you know, these can actually help us to have those conversations and join up those dots. And as you say, why we're doing it, you know, we may as well paint the whole house at the same time, you know. So I think it's a really wonderful observation. The size as well, it's interesting, Andreas, that you had that experience, and you know, and actually it's very helpful experience, because I think our experiences as nurses, and I can only speak as a nurse, I guess, academic, it's always more and more. We like our curricula, we're challenged continuously over the years. When we're actually now in Ireland undergoing a huge curricular review for the undergraduate nursing and midwifery students program, the temptation is not to add more. We're going to really have to challenge ourselves to add less, and to have what we said today, flexible approaches to learning. And I love the slides. I think it was Adriano mentioned about the finance, that could, financial implications of having a sort of a more flexible approach to learning, the openness, the response to diversity. So we have a chance with this new curricula to actually to be a little less. But I think, I don't know what the historic reason is, maybe we tend to be quite driven, quite perfectionistic. You saw on our slides there, patient is the centre of care, patient safety. We always want to make sure we have everything done, and we almost feel everything included, and more is better. And it is helpful for us to see other professions. I mean, other professions have similar safety and priorities and issues, and have an appetite for less. So it's reassuring for us to hear that in the big business world, they're not going to go into, so that's helpful for us. And I think, as you say, if we have more of that sharing, more of those conversations, it will inform us and maybe help us to get to that point where we're able to standardise and make things that small, bite-sized unit. That certainly was the appetite from these regulators and professional stakeholders. That was the sense, and they have a lot of members, so that's their professional experience, like yours. But to finish on Professor Wells' point as well, that we need, and I think it is important, I know it is difficult to get consensus, but I think you're right. I think we need to know what we're dealing with, otherwise we're going to have a very unwieldy approach globally or internationally across Europe. So I don't know whether other colleagues would like to respond. I know, Andreas, you opened the question to everybody. Professor Smolek or Adriana, would you like to?
I don't have a lot to add. Hi, Fiona, and hi, everyone. Again, we haven't seen really.
You're frozen, Adriana.
Well, this path is really good, and this project and this is how we change the attitudes and how implement the real thing.
Yeah. Okay. Yeah. I think one of the challenges that came out, I think, in that workshop is the conflation of ECTS and CPD. And I think not everyone undertaking the workshop is interested in ECTS. So for them, it doesn't matter. So I think one flexible way might be actually to go down the route of recognition of prior learning, so RPL, and on a different micro-credential European-wide initiative, we actually stepped away from trying to force everything into this ECTS bracket, because we call it probably loosely more equivalency, or aligned with, or so that it's recognizable when another university, for instance, you're trying to build something up, so it is at that level, and they can look more closely at, what's actually in it, and they go then through the required recognition of prior learning route. But it doesn't matter then for everyone. You look in the science CPD points, you can also have the ECTS relative equivalency, but then you leave it up to future institutions really to recognize it, and you might shop around, for an institution that actually would recognize it at that level, and level 7, level 8, because I think that's loosening it up a little bit, because we will never, probably agree, even, as you said, John, sort of in Ireland, we have different views on what's a micro-credential, what level should it be at, how many hours go in, and so on. So I think probably uncoupling sort of the ECTS and CPD it probably would be helpful, and then going the RPL route.
Just in relation to that, I don't think we should. Sorry, I don't think we should underestimate that there's for example, within universities. Universities are innately conservative institutions, often populated by very conservative people. And I don't mean it in a political sense, but I mean people who are wedded to traditions and a certain lens and way of looking at the world. And something like this really challenges that. And so certainly, I think within our own domain of our own experience through DDS-MAP in our own institutions, one of the challenges that we've come up against is that conservative resistance to the concept and to change. So even though within Ireland we have advanced the concept, we also have to acknowledge there is still significant resistance to it. And that you're fighting against that all the time. So it's by no means even within the Irish setting, it's by no means universally supported. And that's been one of the challenges, and is a challenge, and as well, I think, and of course it's so linked with what you might call thinking about innovative ways of engagement and teaching, which is again outside of the traditional constructs that we've developed over the years, and that again elicits a lot of resistance. But for me, one of the things has been in relation, it's been a wonderful learning experience about this whole area. I really never really considered it before this project in terms as a learning experience for me around this.
Thank you, John. Andreas.
There's two other questions just waiting, and then maybe are you replying? Yeah.
Sorry, Beat, I have eyes on the floor, so Florian is helping me here.
Just to add to John's example, and as what I said before, one of my assistant customers was the BMW internal training. They trained everyone from the blue-collar worker up to the plant director. The only people that did not train were the board members who had a personal coach, and sold about 40,000 training units per year, every year, worldwide. They coordinated it, and then on all the plants it was delivered. I didn't find barely any training which was longer than 3 days, because even internally they had this problem of how to tie it together. The important thing Helen said this morning is to have it stackable. I understand if you want to go above a certain point, you need to reach so and so many ECTS. But the unit to deliver, to sell to the people who pay for it, which means the department, the director who sends his people in, should be around that easily manageable time scale, which they can plan into their own work table. Because they're responsible not for their people being trained, they're responsible for they deliver the job their department promises. And that means they need a certain reliance on workers being available.
Thank you very much. So maybe the question from the colleague from ESPD.
Hi. Yeah, my question, I guess, is a little bit more, I think, maybe fundamental about micro-credentials and European projects in general. Like in ESPD, I'm the e-learning officer. So we've developed, over the 3 years I've worked there, we've developed a number of online courses, but the vast majority of them are non-accredited. I think there's maybe a number of reasons for that. First of all, going back to who the accrediting body is in the consortium, often there isn't one. And external accreditation can take quite long and it's quite an arduous process and maybe doesn't fit into the same cycle that European projects do. And on the other hand, I think it was mentioned earlier today as well that partners are quite maybe reticent or worried to engage in processes that would continue outside the 4-year or 5-year project cycle, let's say, because the funding works in a certain way and it's finite and resources are seen as quite finite. People are quite reticent to say, okay, yeah, and I'll definitely continue supporting this after the fact because, where does the money come from? Where does the manpower come from? So I was just wondering if there was a comment from even in the room or from the speakers on the sustainability, I guess, or how these two things can be synchronized in the structure that a lot of us work under.
It's a really good point. John, would you like to? Sustainability. Yeah.
It actually relates, of course, to something Andrea said this morning, doesn't it?
Together.
So, I mean, it is a challenge, obviously, and I actually support the EU policy around open access and availability. If a project is publicly funded, then it should be publicly available in terms of results. But you do come up against the real world as well. So so let's take universities. We're rather cash strapped at the moment. Now, we're not as bad as the UK, which seems to be falling apart, but we're not far off it a lot of the time, or it feels that way. What we're doing, how we have dealt with this as an issue, is making the content freely available. But if you want to be assessed for the qualification, we then charge for that assessment process. And that's the way we make it sustainable. It's not the most ideal way because the problem with that is how you update the content, because there's a cost associated with that. So we're covering the costs for assessment, but we're not covering the costs for updating. And that's a bit of a challenge. And so I would also have some sympathy with Andrea saying, well, one of the things, EU puts in, the various funding bodies put in the thing, your sustainability strategy, and rightly so, they're increasing the mark in relation to the sustainability strategy. But sometimes it does feel like we're trying to square a circle when we're doing that. But that's the way currently we manage it. Yeah.
Thank you, John. I'm just conscious of time. Should I pass back to the chair? Oh, those. Oh, and Nicholas.
Yeah, mine is not a question, but more sort of an additional comment to the issue of micro-credentials and perhaps the difficulties as to why we don't agree to micro. Where I go to when I think about this is the fact that the way that we define learning, the way that we define meaningful learning, what do we mean, or what do we think about when we think that someone has meaningfully learned something? And I think if you dig deeper into the assumptions about knowledge and learning, the psychological, then epistemological, ontological assumptions that we make about learning, then you realize that this notion of knowing is stacked on top of an idea of, let's say, reading a bunch of texts. You know, we come from the Christian tradition. If you knew the Bible, you knew. And we went into the secular sort of mode. If you read these 10 textbooks, then you knew. And that notion is changing rapidly, very, very rapidly. And today, when we want to include notions like different learners, different modalities of learning, what we're really doing is acknowledging that there are different ways of knowing the world. And when you do that, you have a corollary difficulty, because then how do you measure that learning? Is my visual learning the same as your auditory learning? It's the same as your reading learning, right? So I think we need to think a bit more broadly about how we define learning and how we empathize perhaps with the different other learners and recognize each other in those different ways of knowing the world, right?
Thank you, Nicholas. Did you say, Florian, those two people online? Two questions online?
We had another question from Dominique, which I'm not entirely understand, so we could ask that question too. And it's around the alignment of EQF to NQF, which through this project I learned is not necessarily the same thing. But Dominique, if you're available, maybe ask the question. Dominique, can you hear us? Normally, micro certification is either a specialization of EQ level 5 or a qualification supplement to obtain a qualification from EQF level 2. It must be directly applicable on the job market. This is how we apply it to our sector. Oh, yeah, if you want to ask it yourself? Oh, she doesn't have a microphone at the moment. And then Andreas, too, if you'd like to ask your question from the transition project. No, from another Andreas. from the transition project, could you, if you can hear me, Andreas Chural Lampus, could you ask your question, which is around transition project is on digital skills, and they're also developing a training curriculum. How do we manage all these trainings in order to get uptake by healthcare providers and health managers? How do they choose, or how do they prioritize? So how do healthcare workers choose or prioritize when they're available? All these different types of trainings are available. Who would like to answer that?
How do we choose? Adriano, your specialist nurses, will they have difficulty choosing or selecting where to start with these courses?
Well, there is always problems with the how to define and how to choose what to use, but we are working a lot and trying to push the project of certification across Europe and to unify all the nursing education. And I think this would be beneficial for everyone to harmonize our nursing education, congresses, symposiums, courses, micro-credential. But sometimes I feel a little bit problematic. But this what Dominique wrote is really clear, but some countries use the micro-credential to put nursing, I will speak for nursing education on the lower level. And well, you can educate through the courses. I said, no. It has to be upgraded on the university level, not go back. Well, I think that can be a problem.
Absolutely. Thank you, Adriano. So movement towards a sort of a framework that might give some uniformity and some guidance and direction for nurses across Europe in terms of finding their way. Thank you.
That would be the best.
That would be the best. Thank you. Apologies, Chair. I'll pass over to Beata for the final word and summary.
No, not a problem. It is difficult to do this job being online. Thank you so much for this great discussion, and probably we could discuss more, and we would find more challenges and barriers. However, I think that DDS-MAP project showed that at least when it comes to cybersecurity and digital competences, we can build good micro-credentials to be an offer for medical and healthcare professionals. Thank you very much. As I mentioned, it is a pity that we cannot be there with you. I hope you will have a great afternoon and the rest of the conference. Thank you very much to the speakers for excellent presentations, and all the best.
Thank you.
And it's a shame that you're not here with us.
Professor John Wells?
It's definitely a shame for
Yeah,
all of us.
we would like to.
We can't say next time because it's a final conference, but you know.
Better to be in Brussels than in my hospital.
So, but the invitation to Croatia is still on, so you know we'll see each other again.
So
Bye.
it's a little bit past 3. We've got a session. Oh yes, sorry.
We have it's a little bit past 3 o'clock. The next session is entitled Lessons Learned and What's Next, and it's to be moderated by myself. So maybe if I say a little bit about some of the lessons I've learned during, and then that will sort of set the tone and give an idea of the theme. So lessons I've learned, lessons that have surprised me. Let me put it that way. One of the lessons that has surprised me is actually the degree to which regulators, for example, don't talk to each other across Europe. And even within nations, they often don't talk to each other. And that's been a huge surprise, because I think sometimes we make assumptions that they are, but they're not. So that's a lesson learned, and I think it's becoming really, really important, because when you look at other developments within Europe, such as the European Health Union, the whole idea is that we become cross-border integrated in order to be able to support each other. And if ever there was a time we did need to support each other, it was during the COVID pandemic. And there is a reason why Europe was led out in terms of vaccination. It's because we actually pooled our resources. So it was a lesson in what we can achieve when we do this. But certainly I think that we need a lot more cross-border dialogue and collaboration than currently exists in this space, which is health professionals, education. And the other lesson that I took away from this is how entrenched the silos are within the healthcare setting in terms of the different professions, and that it's a really very, very difficult thing to overcome. So you read it in the textbooks and the academic papers and the research, but actually if you think about it, a lot of that is reporting on how entrenched the silos are. You see less about successful reporting around how those silos are being overcome. And in part, I think that actually reflects how difficult it is. So when DDS-MAP was happening, when we were thinking about it, when we were starting to do it, we had this concept of healthcare workers coming together, having the same type of experience, but actually it hasn't really worked out that way at all. So Florian said how many people are taking the courses at the moment, which is about 1,600. It'll be very interesting to see the breakdown of that finally, both in terms of not only who started it, but who finishes it. My suspicion is it's going to be mostly nurses, my suspicion. And that my other suspicion is we will have hardly, if any at all, porters, secretaries, ancillary staff, technicians in that profile. And yet all of those people engage with the digital platforms. They need cybersecurity support. They work day to day with all the healthcare professions, and they all know each other by first names. And yet they, I suspect, will not be represented in any of our data. And we need to question, why is that? How did we fail to reach out to them? And are they released? Are they given encouragement to do the sort of courses that we take for granted, frankly, as healthcare professionals? So for me, those were lessons that I'm learning in relation to that. And of course, then there were always lessons that you learn about a project, how you would do it differently if you knew the things you knew now, then. And one of those would be, don't get sick just after a project starts. That's a lesson I've learned. So those would be my reflections in terms of lessons learned. So open to the floor in terms of people's reflections, either on lessons they've learned today or for people who've been involved in the project, lessons they've learned through the project process. So Thilo.
I think I'm connecting with one of the things that you said, John, in terms of healthcare workers, the assumption healthcare workers working together, and you know that they all have shared experience and so on. So one of the lessons that I think we could learn from this project is also some of the approach. Okay, better now. Yeah. Okay. So I think one of the lessons to me is sort of how to approach this whole topic in terms of the engagement of the key stakeholders in terms of the co-production, co-design of the content. And we have pockets of that. We have the workshops in there, and I think they were quite successful. But you mentioned a number of groups there, and I'm not sure that some of the content would be equally relevant for all of them. I think, and so one of the challenges I think is this, and I think one slide said one size doesn't fit all. I think rather than having what we have at the moment, these set modules, I think you probably need to refine and tailor them a lot more, and to different healthcare settings, environments. We have probably in those large numbers of people who took the course, very different healthcare environments. Some are in Europe, some might be outside Europe, some might be in different health systems. Some work in very different team constellations. Some work in very different size institutions. Some work in community settings. So I think there's a whole lot, of variability there, that we haven't probably quite captured yet. And probably also too much to ask of one project of this scale, to do that. But I think that diversity and that requires probably more of an intense engagement process right from the start, just saying, so how do we develop a project like this? How do we engage with the stakeholders? What is the priority? What's the main direction of travel here? And that's of course exacerbated. The challenge is exacerbated by doing this across Europe, across different health systems, healthcare settings, different professions, and but maybe that could be achieved, and perhaps could some follow-on content could develop, for maybe specialized groups in that, but recognizing that they're operating in diverse teams and settings.
Just to say too, like the modules were meant to be sort of generic, which is difficult then to have a generic module that's also specific, but also all the content will be available to adapt and change, first of all, for after the piloting, but then theoretically some of the infographics could be to a different topic altogether, so all the content is there to be adapted and changed, so maybe that could be.
Well, the other bit to that is the budget. It's maybe another lesson learned is actually, if you really want to produce dynamic, discipline specific from a generic platform, it costs an awful lot of money. And I said this in a different setting, the budgets that are on offer that the EU currently offer in relation to what they want for change are inadequate, frankly, in terms of what the funders are trying to achieve. The budgets, as we all know, we actually, with our labour, actually often supplement the budgets. We give more than we get paid for. And even within that, it's still a challenge to achieve things. So I understand, again, at a policy level, decisions have to be made around resources, but sometimes the things that we're trying to achieve, the budget's just not adequate to do that.
I'm just going to say, even in our context, we're thinking about adapting the modules for all staff. But that's a whole different population.
First, then Andreas.
Sorry.
Thank you very much. My name is Olayinka. Mine is more like a what next, and I'll talk a little bit about lessons learned as well. I think this is an EU project, and if we think about the diversity, like Silo mentioned, we need to have more diversity even in the workforce as well. I remember even when we were doing the recruitment, we had to look like targeted adverts, and recruitment. How do we involve people from Africa who are in Europe? And that comes with a collaboration as well. And you mentioned about silo working. So even the systems are there, the healthcare organization is there, but they're not working together. So I think if we're outside DDS-MAP, looking at how we can build our connection across all communities, so that we can have robust input in future projects. My what next was to talk about now the healthcare professionals and allied healthcare professionals are getting equipped, but there seems to be a huge gap, in the implementation, like the reality when they come to the hospital, for instance. So it's good to learn virtual reality. That was very brilliant as well. But one of the things that will determine the uptake from these healthcare professionals is, can I apply to my current work experience? So, and we need to start thinking of that. And Ireland now, there's so much fragmentation, even in care, digital scale, infrastructure still, crawling. So how do we now bridge that gap from the learning and everything we are taking in? Then there's that gap, then there's nothing to practice. So if I'm getting all the skills and there are no infrastructures, there are no support system in the workplace to use them, then where are we heading to? So I was going to ask the EU rep that was here about what the EU plan is in terms of, I know this is maybe bigger than this room, digital health technology infrastructure. We've been talking about this forever. Like every conference I go now, it's about digital health, but the implementation is still far-fetched. Thanks.
What I would, please clap. What I would say, of course, in a way, what you're identifying there is within member states, health services are funded differently and at different levels. And we have EU member states that are financially quite poor. and other EU member states that are very wealthy. What they all share in common, of course, is health services that are under strain. Even the well-funded ones are under strain. And probably that problem is not going to improve. It's probably going to get worse. And the reason it's going to get worse is we're going to have to divert more resources to military defense. You know, we've lived for the last 30 years on the back of the fall of the Soviet Union. Now what we find is that the Soviet Union is announcing that Russia is back. And that means that we're going to have to, and indeed yesterday, all NATO members agreed that they were going to raise defense spending to 5% of gross domestic product. Well, you know, the money has to be found somewhere, and what I advocate is that we need to see healthcare spending as a defense asset, not as a social need, but as a defense asset. And therefore it needs to be, spending needs to be at least protected at the very least, but probably increased. But that does mean money has to be found in other areas, and that may well be things like social welfare support for people who are unemployed. You know, the money will come from somewhere. Higher taxation. We might have to pay higher tax, and we've all got very used to, by and large, a much lower tax burden than our parents had to have. And any politician who goes out and says, I'm going to increase your taxes by 10%, is likely to get lynched, certainly not going to get elected. So it's a very, what I'm saying, as I would see it, Olienka, it's a very complicated arena. Starting from the income differentials and expenditure differentials between each of the member states within the union, I think.
So before I come to my lesson learned, comment on yours, that is a very Irish comment, because in Germany we already pay 46% of taxes. So from that point of view, not interested in an increase.
In relation to health, not in relation, at the moment you're raising your military expenditure, but you're talking about the context of health.
No, I'm speaking in total. The tax which we pay already, where all these things are paid for, are 46% as an average in Germany. So I'm sure my parents didn't pay more than 50% of taxes.
Well, I shall tell you something. In Sweden, up until the mid-1980s, the tax burden was 80% after a certain level.
Yeah, but
so high, and which was the happiest country up until the 1980s? It was Sweden. So I'm making a broad generalization. I acknowledge that, but nevertheless, tax burdens were higher in the past than they are than they were today for many people.
But coming back to the lessons learned, for me, one of the main lessons learned in this project, which was reflected also in other projects a little bit, but here was very strong, goes on redesign of how the project is running in some cases. We lost a lot of effort and resources by not training each other very early in the project. Especially me with the organizational self-assessment. We called at the beginning self-assessment. And the self-assessment for the people who were educators was completely different from me coming from a business environment background. Until we understood it, we already had designed 2 or 3 times the assessment catalogs. This time could have been heavily reduced if you would have taken the time at the beginning of saying, we come from so many different backgrounds. Let's take 1 or 2 day training where we inform each other what we understand from what we do, or at least the core partners we need to interact with, because the time spent for this would have been gained afterwards in this 2.5 years many times over. So perhaps for future projects, do something on the project management where say, oh, we have a 3 days workshop at the end of the first quarter when everyone knows already a little bit where we go, to just inform each other. Where do we see our own work package to go, and how do we interact? Which are the partners I need to work actively with me and not only control the results to get for it? I think that would have saved us in this project a few man-months in total. And we could have spent these in other resources. Not to have good results, but to have even brilliant results in some cases.
Anyone else?
Thanks for that. Just, I suppose it's a point that I was made very aware of by the research we did before the start of this project, and I suppose the reason why I got involved in the project was around the experience of healthcare workers of the cyber attack and how traumatic it was. So, you know, this is a very welcome project, but unless, and we're talking about money and big money and investment, and that's not happening, you know. And I know from the Irish perspective, our healthcare infrastructure is on very weak foundations in terms of the IT, you know, and there isn't a significant investment coming anytime soon, unless you're talking about the new children's hospital, which will be, you know, state of the art, you know, digitally, paper light. It'll be quite well advanced, but other healthcare areas won't be, and they will still be trying to operate safely. You know, we're educating these people, but they're on shaky ground, and you know, you're asking a lot. You're asking a lot of people who are under strain to try and operate safely with these really clunky systems that don't speak to each other, where they have, you know, different systems with different passwords, and they're coming up with these workarounds so they can work efficiently, but they're not working safely. So education is great, awareness is great. You nearly need a whole movement, but at the bottom of it, it's massive investment that's needed too for proper cybersecurity, digitally aware and very conscientious healthcare practitioners at the bed space.
Because what I think that it really highlights, what your point is making there, Claire, is that when we deliver training, what we have to take into account is real world situations and why people have those practices, isn't it? And I think of myself, you know, because it's so burdensome to try and have different passwords for different things, I have one password, which I'm not going to tell you what it is, but it's one that's easy to remember, and then I vary it by the year. My son hears of that, and my son hears that, and he goes white with fear. He works in the cybersecurity industry, you know, but he works in an industry where doing those sorts of things is part of his day-to-day practice. He doesn't have to worry about, as a nurse or a doctor would have to worry about, going from patient to patient, needing to input data quickly because somebody else then needs to be called upon. And what's one of the things you do? Well, you cut corners because it's the only way that you can get the job done in the time frame that you have. And, you know, and then what we do is say, you're doing it all wrong. So actually what we're doing then is adding to their stress, because they know they're doing it wrong, and now they feel guilty about that. And they try at best after the training to keep, but the practices change and the cuts creep in. So it is a challenge for us. How can we create something that will help them deal with their real world challenges and not burden them with stress and guilt when they know they're having to cut corners because they know they're doing it wrong? So I would completely support what you're saying. Yes, yes. And that's the other bit. The dynamic is so fast, and we experience it in our own settings, don't we? We just get, you know, they've just abolished Skype. It took me 10 years to master Skype, and now they've abolished it, and now they want me to master MS Teams. You know, and that's just a very simple one. It's nothing like the challenges that they face in the clinical settings in terms of changes. So it's deeply frustrating.
What's striking too is because Ireland had a full-scale cyber attack. For people who don't really understand just how extreme it was really like the research that Claire and John did too. Is that some people consider that worse than the COVID, but at the same time, they didn't report in the survey much higher. They showed higher interest in cybersecurity training, but didn't show much higher engagement with cyber training, which is interesting because no other country at the time would have had the same sort of attack. But why didn't they do the training? Is it because they don't have the time or some of the other reasons? Yeah.
Their role in the firewall. They didn't see themselves. Everything was referred to the IT department, which is very separate to the clinical areas. The IT department is very far away. It's really not part of the system in terms of how you visualize that healthcare system. You know.
Yeah. So I think I just wanted to build on that in terms of, I think when we did the co-creation stuff and, you know, even the research that came before really informed developing some of the scenarios in those modules. And I think the value and the benefit of having the generic modules there that are open access means that through co-design and involving specific professions, so they get ownership over kind of that learning content and everything, provides such an opportunity to tailor it in different contexts, but still align it with a broader European model. And I think people find it easier when they have something to start with. And in the time frame that the project had, I don't know if it's possible to kind of get to that real specific profession point, but the availability of somebody else to pick that up and then do that, I think, is really important to acknowledge. But yeah.
And I just want to ask now, DDS-MAP, is there a link back to HSC, for instance, in Ireland, or to the government's bodies in other, countries? Because at the end of the day, it becomes like you've done yours and that's it. And HSC, they're doing their other projects as well. Is there a way we can link up, something like that just for Irish context, but I'm sure other countries have their own healthcare system. So it's not like a silo project and we have different projects, everybody running their projects. Just a link for we have done this now. These are the recommendations to HSC or something like that.
So a couple of ways of answering that. The first way, obviously, is the way that we make contact with regulators and making them aware of the project in our respective jurisdictions. That's one way. The challenge in terms of follow-up from our end, it goes back to Andreas's point. Follow-up is a resource-informed activity. And that's often where these projects end up, is that they come up against the reality of resources. So just to give you a little example, a few years ago, we developed a very good mobile application to support students with their stress whilst they were in clinical placement. And the content was very good. We had very good feedback. It was very well evaluated. And quite a professional app for the budget that we were given. Our colleagues from Slovenia were involved in that project, as was Andreas. What happened to that was, when the project came to an end, we had to make the app freely available. We advertised it and connected. In fact, I think, was it someone from UCD was going to engage students from UCD, or you were holding a workshop with somebody? I can't remember, Florian, but anyway.
I can't remember either. Which
no, but that's because you're getting old, Florian. But
was it with Claire?
There you go, you see. It was Claire. It was Claire, wasn't it? Yeah. 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 And then it came up. We got a budget demand a year later to renew the subscription for it to be hosted on the platforms.
Low key, I was paying for a little bit for a couple of years too.
And so we found some funds from our own budget to maintain the application, but the reality was that could not be an open-ended commitment. And I couldn't persuade finance that, you know, it was going to be something that we should fund as a university. So it died.
Especially for the other language areas.
Yeah, exactly.
For the app shops, you have to pay this for each country.
Yeah.
So why the hell should you do it for the Spanish or the Slovenians or the Germans?
Yeah.
To keep it on, and if there's no partner who has their university curriculum fully integrated, why should they pay for it?
And the other aspect of that was the app had to be maintained. So it wasn't just paying for the platform, it was maintaining the app, which again would be quite in the scheme of things, a significant cost. So it was a great shame. It was a great resource, but it died because it came up against post-project realities.
Yeah. And that's why I always argue to make it browser-based and not app-based. Because then at least our application I have to maintain anyhow as the library. As long as the library is running, it's relatively cheap to adaptive for each sector. The library is, I can first ask people to pay for from our commercial development. I don't have to use new research projects. So we can solve it a little bit. But if you're really saying, I optimize it for a smartphone app at the beginning, you can only send it from an app store. And then you meet post-project these barriers.
I think a thing too, I had another experience where we actually won a prize for an app we developed, and it was funded through Erasmus, and then it got funding from the Global Fund, from the Robert Carr Fund, and from a few other different groups. But then they ended up, no one knew who owned it anymore. And now it's stopped, I think, as far as I know, because no one had ownership over it. So I think the thing about DDS-MAP results is making them open access, and so people can use those materials in whatever way, like hopefully together in consortia, but for other things.
Having said all that, there are at least 3 follow-up projects that will follow on from DDS-MAP. Many of you here, I hope, are going to be involved in those when we progress it. But that obviously the progression will be all based on EU money. Tilo wants to make a comment, and then we'll move on to the next
thing. A little bit in with that, future projects.
I just need to listen to Tilo. Hang on.
I mean, one of the lessons I think also is by what we focused on in terms of the development, the experience and getting people involved, it's very much on a past present focus, so what's the knowledge of people at the moment, what do they do, what have they experienced, what they would like to see. But I think what's equally important, or we probably haven't quite touched, is the present future focus, because we talked a lot, how rapidly the field is evolving, so the content that we and that's equally relevant, because we've demonstrated, we've seen, through surveys and interviews where the knowledge and the awareness is, but I think there's this whole vast area out there that hackers and we talked about that in the break, hackers are aware of, where the security risks are, and they're coming down the track. So we need to be prepared for that and be ready for that. And so the training has to set in now for that, and not just for the stuff that we're aware of, because we have to open up that new horizon, in terms of what will come down the tracks.
I think that's what they said, when you're always fighting the last war, isn't it? Rather than, yeah. We're going to finish up.
Just a little segue on the Athena.
Yes, that's what I was going to go on to Florian. Florian gets a little bit anxious sometimes, and I have to reassure him. So, we just want to make a little announcement. It relates to one of the things that we're developing as a platform for developing the DDS-MAP concept further, but actually engaging with the issue that Tilo raised at the end, which is developing a community of practice and thinking that's forward thinking, foresight planning, and will bring, we hope, our own expertise together through this and thinking about this and become an influence and for project development. So we've established, we were very, actually, we've achieved, this is an outcome for the project so that you're aware. It's a good outcome. It's a really difficult one to achieve. We've been accepted to establish a community of practice platform on the Agora EU Policy Forum platform. So we've established a group called HaDEA. And HaDEA is the acronym for, and I can't remember what it stands for, but let me just say it's network and agility. That's what I always remember about it.
Actionable transformation of healthcare using network agility.
Now, why have we chosen HaDEA? I want to emphasize the way she's looking is not significant, the direction in which she is looking is not significant. So don't read anything too much into the direction she's looking. But HaDEA, if you know your classical mythology, HaDEA was the goddess of strategy, wisdom, tactics, and victory. And she was always forward-thinking and foresight-thinking. She married, actually, Ares, the god of war, who was just brute force. So I've often thought that we probably get the concept of behind every great man, there's a greater woman from that relationship. And we thought that as a character, she represents what we should be engaged with. That forward-thinking, strategizing, aiming to win idea. So we came up with HaDEA, and that's what the platform is about, establishing a community of practice that is going to think about the challenges that are going to confront healthcare workers and services going forward into the future. So trying not to fight the last war, but try and think of things that are coming down the track so we can be prepared. So that's the platform. We very much would love you and would like ask you to join it. It's going to be a place that we want to provide a forum for discussion, project development, but also we're going to look at developing a monthly podcast associated with the platform, where firstly with ourselves, and hopefully if it gets popular, we can then attract senior people across Europe to come and talk about what they think is going to be the issues that are going to be affecting healthcare. But there are two obvious ones, as far as I can see. One is climate change and the other is conflict. Will be the two things that are going to be defining healthcare for at least the next 20 years. We're going to associate 3 potential projects with this, and we develop them through the HaDEA platform with hopefully yourselves, and look for EU funding in the context of that. It's also going to take the concept of healthcare in its wider sense. You know, for us in these areas to develop healthcare and deliver healthcare, we're going to be engaging with all sorts of fire services, police services, regional governments, and so on. So we will be encouraging those types of services and representatives also to engage with the platform. But the links there, we will talk again tomorrow in the project meeting about it a little bit more, but we would just want you to be aware that it's there, and we would want you to join up, and then we can think about structures and so on within the platform once we've done that.
And it's linked to your European portal. It can be sometimes to get signed in the first place can be challenging. So if anyone has any issues, especially tomorrow, I'll go through with them.
Thank you, Florian. So we're coming to the end. I know that Omar will need to come and say a few things in relation to that, but before he does that, what I'd like to do first of all, and I think they deserve a round of applause, is Omar for organising the day on behalf of ESPD. I think he's done a wonderful job with his colleagues. So I think we should also give Florian and Keith a round of applause for selling the VR so well today. I know Petrina has been immensely impressed by the project and all of you today, because she said that, and that's a really good win for us, I think, as a collective. So can I just also say, I will say it again tomorrow, but it's been a pleasure to be with you all today. I'm so glad I can say that, that it's a pleasure to be with you today. Thank you. So, Omar,